Good morning and welcome to the virtual 13th Annual Retina Symposium. First and foremost, I hope that you and your families are doing well during this time of the COVID-19 pandemic. It's really an unprecedented time in the history of our country. And currently, fortunately for us, with the current technology, we can make use of this time and actually learn and share information, despite the fact that we can't meet in person. So I'm giving you all a virtual hug, virtual hugs to you all, and hopefully sometime soon we can all see each other and greet each other in person. So our symposium this year is entitled The Future is Now, and this title reflects the fact that as little as 10 years ago, much of what we're going to be discussing today was the stuff of the future. Indeed, there have been major advances in medical and surgical, diagnostic and therapeutic areas, and today we're going to hear about these technological advances such as AI and CRISPR and new novel therapies and applications to what we can do in our field. So our speakers are going to talk about these advances that made the future is now. So I'm going to go ahead and share my screen here. I'd like to introduce our invited speakers listed here: Robert Hyde from the University of Michigan, Kellogg Eye Center, Alice Lyon from Northwestern University, Dimitra Skondra from the University of Chicago, and Stephen Tsang from Columbia University. I'm grateful for them for sharing their knowledge with us today. I also want to acknowledge my UIC faculty, speakers, and friends as listed on this slide, and I'll introduce them separately later today. I want this to be an interactive meeting. There is a chat feature for which you can use to ask questions during this meeting. Also, please complete the CME survey at the end of the meeting in order to receive CME credits. Our first speaker today is my colleague and friend, Larry Ulanski. He is the Acting Clinical Director of Surgery and Chief of Ophthalmology at the James Lavelle Federal Healthcare Center. He is also the Clinical Assistant Professor of Ophthalmology at U of I, and he'll be speaking on prevention of AMD progression in 2020. What is the role of remote monitoring? So let me pull up Larry's talk.
I would like to thank Dr. Lim and the UIC Retina faculty for allowing me to participate in this, the 13th Annual UIC Retina Symposium. The future is now. I will be speaking about the prevention of AMD progression in 2020. What is the role of remote monitoring? Today, we are all facing many questions in the middle of the COVID-19 pandemic. And this particular topic is quite timely and appropriate for what we are all facing as we try to deal with patient care when we cannot see our patients and are very scared to bring them into our offices. Hopefully this discussion will bring new ideas and new thoughts to how we can handle this not only today, but in future events. I have no financial disclosures. I will not be speaking of any non-FDA approved therapies or medical treatments. I did serve as a site PI for UIC for the 4C home clinical trial. The objectives of this talk is to review the need for home monitoring of our patients today. We will also review data supporting the 4C home device use in the clinical practice today. We will also introduce novel technologies which we may be able to incorporate into our clinical practice in the near future. Macular degeneration affects a large portion of the population. Between 13 to 14 million people may have dry macular degeneration, and 1 to 2 million people may have wet or exudative macular degeneration. Those patients that are at highest risk conversion from dry to wet AMD typically fall into AREDS Category 3 or Category 4, representing 54% of all the patient population with dry AMD. They have between an 18 to 42% chance of developing exudative macular degeneration at 5 years. These photographs demonstrate advanced dry macular degeneration bilaterally with soft billowing drusen and vitelliform deposits in the left eye. Over time, these drusen absorb, and in its wake is left geographic atrophy, RPE loss, photoreceptor loss, and a poor visual outcome. Wet macular degeneration is also not a stationary disease. Choroidal neovascular membranes may grow 18 to 20 microns per day. We know that smaller lesions, smaller CNVMs, lead to better outcomes via the MARINA and ANCHOR trials. These graphs from the 2-year CAT trial results demonstrates early intervention and early treatment leads to better outcomes. If a patient comes in with better vision in the beginning of treatment, typically they can maintain vision. If they enter with poor vision, Rarely is there significant improvement over time. The 5-year CAT data demonstrated similar results. At 5 years, it shows that patients who had good vision typically could maintain good vision, and patients who had poor vision typically continue to have poor vision. Though over time there was slight regression in vision, the majority of patients were able to maintain good vision with treatment. Similarly, the OCT data at 5 years demonstrated that retinal thickness did not change over time with treatment, and that retinal thickness was mostly stable over time. Our way of traditionally monitoring dry macular degeneration patients is with the Amsler grid, which was introduced in 1945 by Dr. Mark Amsler. The grid is projected onto the macula, central 25 degrees, and the patient notes distortions in the grid based upon changes in retinal morphology. Those changes in retinal morphology rely on the patient's memory of previous distortions in the macular grid. Therefore, that subjective measure introduces low reliability in the patient's ability to detect small changes in the fovea and in the macula. The 4C home monitoring device was developed to measure retinal morphology and metamorphopsia changes in an objective manner. The device projects lines onto the macula and uses vernier acuity to measure distortions in the retina and the macula. The 4C home device relies on hyperacuity or vernier acuity for 2-point discrimination versus the Amsler grid, which relies on visual acuity or pure resolution of a static object. Pure resolution of a static object for 2-point discrimination can measure and detect 30 to 60 degrees of arc difference. It's also affected by age and blur. Vernier acuity or hyperacuity can detect as little as 3 to 6 degrees of arc and is an order of magnitude more sensitive. It is not affected by age and is not affected by blur. So how does it work? The 4C home device shines a line of dots across the patient's macula. When the patient sees the dots flashed across their macula, they may notice a distortion in those dots or a deviation of the dot from others and mark that with the mouse on the screen. When a new choroidal neovascular membrane is present, it causes distortion of the photoreceptors. That distortion makes the patient perceive a distortion in the line projected on the retina, and that patient will mark that area with a mouse. Over 500 points are tested across the macula in 14 degrees of the central field within 3 minutes. I'll show you here basically what happens. The line up to the upper left, there's an artificial distortion. The patient clicks and you can see the correct marking below it as an X, green X. The next line is projected and the patient again identifies the correct distortion and an X is marked. The third slide to the right, the patient has a CNVM which is identified in the fluorescein with the white dot, and the patient clicks on that instead because that is the new distortion that they've just identified themselves. This creates a metamorphopsia map. This map is where these distortions are seen by the patient. It's flipped upside down and inverted. It's shrunken down and scaled down to retina dimensions, and then you can place it over the picture of the fluorescein and you can see exactly where the leakage is coming from, and that's the metamorphopsia map identifying what the patient has self-identified as the distortion. A baseline is established as far as distortions, and then you can monitor these distortions for changes. And these maps can be monitored over time, and you can get a red line here, which is a suspected change, and if you go over a threshold, a warning is set. In this particular instance, the patient was testing 7 times per week. They were a very good patient, and obviously this was early in the trial. The problem is, with this testing methodology, you are reliant on the patient objectively testing frequently in order to get a result. In this instance, here approximately 7 years later, the patient's only testing once per week. And early detection requires frequent testing, and early changes may be missed if the patient is not testing frequently. In this slide, you can see that there can be changes in the metamorphopsia map that are not related to exuded macular degeneration. In this patient, over the course of 6 years, there's advancing dry macular degeneration and increasing drusenoid deposits under the retina, which increase distortions in the metamorphopsia map. The OCT confirms there is no subretinal fluid or signs of exuded macular degeneration in this patient, but there is no significant IS-OS loss in drusenoid deposits under the fovea. Well, what are the results? There are 4 large studies that were performed with the Home 4C device that demonstrated clinical significance and improved visual outcomes in those patients who used the device compared to the ambulatory grid as control. In the NEI, NIH-funded home study, 1,520 participants were enrolled, 83% of which had large bilateral drusen. 16% had advanced AMD in their non-study eye. The results. The study was actually terminated early because the patients who used the home 4C device had significantly superior outcomes. Compared to control, the proportion of patients who had detected a CNVM before losing 20/40 or worse vision was 87% in the treatment group versus 62% in the control group. More testing resulted in higher detection, with 94% detection if you test it more than 2 times per week. Also, those patients who lost significant amount of vision, 15 letters or more, was significantly less in the patients who had the home 4C device at 6% versus 23% control group. And the number of, quote, scheduled visits was significantly reduced in those patients who used the device at 21% versus 45% in the control group. To date, over 6 million tests have been performed with this device since the study. And as we know, it is clear earlier detection leads to better visual outcomes. As you saw previously, in the CAT2 trial at 2 years, those patients who started with good vision typically ended with better vision. And those patients who started with worse vision typically did not improve vision significantly. We know that early detection is important. Young lesions grow faster than large lesions. Young lesions have more VEGF receptors compared to mature lesions. And third, gene expression is strongest in the first week after CNVM is induced compared to 4 weeks later. To demonstrate the significance of early detection and early treatment, this clinical scenario, the patient was seen between 2005 and 2017 with 139 encounters. During that time, the patient did participate in the AREDS trial and also the 4C home device trial. In 2010, the patient noted a significant drop in vision to 2100. On OCT, she was found to have fluid and she was started on anti-VEGF therapy, and the patient returned to 20/30 vision. Between 2010 and 2017, the patient had an additional 49 CTs performed in multiple anti-VEGF therapies. In this example, in December of 2016, the patient had 20/30 vision, but in December, 2 months later, she still had 20/30 vision, but demonstrated a small distortion or waviness in her vision, didn't quite think she was seeing well. She noted on OCT to have significant intraretinal fluid and thickening, and anti-VEGF therapy instantly resolved the fluid and brought her vision back to baseline. While we have shown that the home 4C device is helpful in detecting early changes in AMD, which leads to earlier treatment and better outcomes, our purpose of this talk is to speak of the future, and the future is now. And this talk will show you novel ways that we may be monitoring our patients in the near future. The ability to monitor patients and look at their retina at home has been a long-standing dream for many retina specialists. Well, the future may be now. In 2018, Mocha and his colleagues demonstrated a device at FARVO which looked like OCT imaging which you would get from a Heidelberg OCT, but in a home device. Nodal Vision, the makers of the home 4C device, recognized this unmet need and also worked on a home OCT device, which is now in clinical trials. So the future may be now. In 2018, Nodal Vision home OCT was designated a breakthrough device by the FDA and granted fast track application. The device uses artificial intelligence to study the central 10 degrees of the macula for intraretinal and subretinal fluid. In its pivotal trial, 196 patients were enrolled with 309 eyes. The device demonstrated 92% sensitivity and 97% specificity. Of the patients that used it, 97% stated that it was easy to use. Nodal Vision is not alone in this market. Kubota has a home OCT also in their pipeline. This home OCT is part of their home patient monitoring application suite, which they are trying to develop for ophthalmology. Compact Imaging is a company out of Europe that is using the technology introduced by Maloka and colleagues to bring home OCT to the masses. Compact Imaging is using a multiple reference OCT as their technology platform, and they've recently signed a collaboration agreement with Novartis to bring this technology to the market. At this time, however, there are no commercially available home products on the market. So while the future may be now, we as clinicians must remain skeptical and observant of our patients' visual complaints and symptoms. We also must remain skeptical of any new technology which may bias our clinical decision-making process. In this particular instance, the same patient I showed you several slides ago presented with small distortion of vision despite being 20/30. There was no signs on clinical exam of a CNVM. OCT demonstrated a small subfoveal mass right under the center fovea without intraretinal fluid nor subretinal fluid. She received anti-VEGF therapy, the mass resolved, and she had complete resolution of her distortion. So the question remains, would artificial intelligence find this small elevation, or was I biased by my long-standing relationship with the patient and observation of many OCTs of the patient over time, and that collective knowledge drove the decision-making process which identified this small lesion? While we may be excited about new technologies today, the unfortunate truth is there's still 17 million people affected with macular degeneration today, and that is expected to grow to 50 million by 2050. There will be no flattening of this curve without new technologies for earlier interventions for better visual outcomes. While we all are excited about new technologies on the horizon, the unfortunate truth is 17 million people are affected with macular degeneration today, and it is expected to grow to 50 million people by 2050. There will be no flattening of this curve without more advanced technology allowing earlier detection for earlier treatment for better visual outcomes. I'd like to thank Dr. Lim and the UIC Retina faculty for allowing me to participate in this, the 13th annual UIC Retina Symposium. The future is now. Thank you for masking in public. Be safe. And also, thank you for participating in this remote learning event. Have a good day.
Thank you so much, Larry. That was a wonderful talk on the PHP machine as well as the home OCT. I think we have a few questions, and we'll go ahead and take those here. Let me just unshare my screen, and I can see the chat. So Larry, if people are asking, you know, this is sounds like a great machine, and what % are capable of using it, and why aren't we using it more?
So in my experience, I feel about 90% of patients could actually use this machine. There's of course around a 10% that just couldn't get it, whether it was dexterity, whether it was attention span, whether it was, you know, mental capacity. But you know, most of our elderly patients now are very computer savvy. They know how to use a mouse. They know how to point and click. So I think that the acceptance of this is going to actually grow with time as you know, as people, as our generation actually kind of enters this phase. The next thing about it, as far as acceptance, I think one of the difficult things has been the reimbursement model for the company. They contract directly with Medicare. So there is a cost for the service, approximately $60 per month to monitor this device, but there is actually not reimbursement back to the offices and to the clinician. So you can see this dichotomy where, you know, people, they like the technology. I think if you are in a place where getting into the office is very difficult in a remote location or rural areas, probably this has more appeal. But in an urban area, such as Chicago, more likely than not, we're going to have these patients come back to our office for a direct examination, OCT, and interaction. So I do think that there's room for this to grow and have more acceptance in the market. It's not you know, like a therapy where you have a direct reimbursement for a treatment that you provide or a fee for service. So I think it's something that's going to take some time for more market penetration and acceptance.
Okay. Yeah, I think the home OCT is really going to be a game changer in our field if we can get it, and, you know, down to a reasonable price. And I think it'll have a big difference in how we can care for patients and limit the amount of patient visits that we need to see. Anybody out there have any questions or comments regarding the home OCT?
The one thing I would say about the home OCT is think about it like this. If there's multiple providers and multiple makers, and you know, this is an open platform, you're going to see a lot of competition in this market, and it may become just like a blood pressure machine, and everybody that has macular degeneration gets one just because that's what you need to monitor at home. I think the combination of early detection for dry macular degeneration and the ability to monitor wet macular degeneration will be a nice combination.
Great. I think it's really going to be a game changer. It is the wave of the future, and the future is now. So thank you so much, Larry. Our next speaker will be Dr. Alice Lyon, who is a director of the Retina Service at Northwestern University. And her talk is actually on my assistant's computer. It just came in, so I'm going to have to share with V. V, I'm going to go ahead and let you take controls right now.
Today I'm going to be talking about diabetic macular edema 2020. For full disclosure, Northwestern is a DRCR Retina Network site. I do serve on DSMCs as noted, and we do receive grant support from various companies. I will discuss the use of FDA-approved medications for non-approved uses as noted. Diabetic macular edema is, as we all know, the most important component of the diabetes epidemic in terms of vision loss. Diabetic macular edema is still the leading cause of blindness in working age adults in the United States. It is asymptomatic and vision loss is late in the course, and we all know it's very difficult to get the vision back. Duration and severity of diabetes has a lot to do with the when they present. The medical status, we're all familiar with glucose, A1C, blood pressure, and cholesterol, and the associated comorbidities, smoking, hypertension. Diabetes control and monitoring is the key to the best success, and we are the people who end up mopping up the lack of success. Medical management is the most important component. Technology has really changed renal failure to hemodialysis and kidney transplants. Urine dipsticks have become continuous glucose monitors. Multiple insulin injections has now become standard of care for insulin pumps. Pharmacology has also dramatically changed. Insulin was pretty rudimentary to begin with, and now is long-acting, and then there are many different insulins. In addition, there are multiple drugs and many new targets. The technology has also changed dramatically in ophthalmology. It went from the ruby and the handheld lenses to OCTs, and fluorescein angiography to OCT angiography, pituitary ablation to laser photocoagulation, one laser with few lenses to multiple lasers, multiple lenses, indirect laser, and even pattern lasers. Blindness with vitreous hemorrhage to high-tech small incision vitrectomy. We've made much progress. I still use fluorescein angiography on almost every patient with diabetic macular edema who I see, but I also use the OCTs. In terms of pharmacology, we talked about 1 to multiple daily insulin injections, the long-acting insulins, and the addition of multiple agents. The biggest change for us is the switch from laser to anti-VEGF, from a hammer to much more appropriate treatment. There are 3 in clinical use actively and many others in trials. I'm going to be discussing about the frequent intraocular injections, and the next talk by Jenny Lim will be more with the more experimental treatments. So what we have now is the pharmacology and the technology that has allowed us to not only examine and figure out what's going on from visit to visit in a very safe manner, but also to be able to treat in a very safe manner. We all know about lasers. Lasers are proven. This was the 1976, the DRS 86 with ETDRS, and it wasn't until 2008 that DRCR Net came together and really proved that laser was superior to triamcinolone, and subsequently with Protocol I proved that anti-VEGF was superior to laser. This is what we all learned. PRP all the way to the arcades, dense white burns, and clinically significant macular edema. I think very few fellows and residents even know what these definitions are anymore. But if you ask any of them how to treat, they will tell you you give an injection. We got intravitreal injections for everything. But how do we decide? How do we decide how to treat these patients? The most important factor, I believe, is really the prevention. The prevention is essential. It's essential when you meet them the first time, every time you talk with them, and whether you come in with florid proliferation and rubeosis, there is benefit to maintaining or to improving control and to both to their eyes and to their well-being. We all know about glucose control, blood pressure, cholesterol, obesity, and inflammation play a significant role. These are very difficult things to tackle, but it is a teamwork between the ophthalmologist, the patient, and the endocrinologist. We can't stress enough the need for medical evaluation, monitoring, and to be on top of their medications. Okay, so talking about how we treat and how I treat. DRCRnet and Protocol I is revolutionary. It really changed the treatment of diabetic retinopathy, even more than the laser did in 1976. The anti-VEGF has very clearly been proven superior to the laser. The Protocol I was with center involving macular edema with patients who had loss of vision. Ranibizumab was used. The multiple injections were required. They were also proven to be very safe, and that over time, many fewer injections were needed. This is burdensome for the patient and the physician, requiring multiple visits, injections, and expensive and time-consuming. We also have 3 different agents, and now question is, which do you use? When do we use it? And I believe everyone has a little bit different take on how to select that for various reasons, some having to do with efficacy, some having to do with cost, some even having to do with the facility of using the various agents that are available. So we have 3, ranibizumab, aflibercept, and bevacizumab, and Protocol T showed that all 3 are effective for eyes with center involving DME. Ranibizumab, aflibercept, and bevacizumab are effective in treating diabetic macular edema. If the vision is mild, they are essentially equivalent. If the vision loss is more than mild, if it is intermediate or it is much worse, then aflibercept is better, has a better visual outcome, as was Protocol T. And it's a pretty busy slide, but basically showing the change in visual acuity over the cohort. The entire cohort is the top. The eyes with it's a little bit hard to see right now. The eyes, but basically, all 3 of them improved the visual acuity. And overall, what was also shown is that the aflibercept was more effective at improving visual acuity if the initial visual acuity was 20/50 or worse. When the vision was 20/32 to 20/40, they were relatively equivalent. So we now have all switched to using anti-VEGF. We are comfortable using all 3 of the currently available anti-VEGF. And in the protocol, with giving 6 injections and having to then taper it off, it was decided to follow up for a full 5 years. So Protocol TX was created, and then Protocol TX for 3 years after the study. So Protocol T lasted 2 years. Protocol TX went from year 3 to year 5. About 2/3 of the patients who were eligible did show up and were participated. The mean retinal thickness was similar. The mean vision declined, and it was very similar in all 3 of the groups. But it did show in all of them that there was a decline, a steady decline in vision at 5 years. So what we see is at 5 years, probably with less vigilance of visits and injection, and perhaps even less control of their medical status, the vision declined in all groups in a very similar way. And the OCT also basically was similar at the end of 5 years. But the area under the curve really showed that the ranibizumab group, this is for the other study, I'm sorry. And then for protocol V, this is a very exciting study because this helps us understand at what point we need to initiate treatment or how long we can delay treatment. And protocol V, eyes with good diabetic retinopathy but good vision and still having center involving macular edema, were randomized to observation of aflibercept or laser. And at the end of the study, they were very similar. It was very important to note that many eyes never required any anti-VEGF in the observation group or the laser group, and that the 5-letter loss or the more than 10-letter loss was similar in both groups. Initially, the aflibercept was better, but they were all very similar. And this shows us that some delay in treating macular edema is safe in these eyes. They don't need to be treated immediately. And soon we're going to find out the results of protocol W. I call this the WOW protocol because we're taking patients and trying to prevent loss of vision. They have to have severe NPDR and no center involving DME, and they were randomized to sham or observation. And this protocol is finishing up shortly. We should have results, I believe, towards the end of this year. The other protocol that we're waiting to hear about is protocol AB. I call this the anything but protocol because it's the patients who don't want surgery and they're happy to have injections, and this is also in final stages. So on to a couple of patients. So I saw a patient yesterday who was a good example. Here's his right eye. From left to right is his initial visit, his second visit, and his third visit. I think they're about 2 years apart from beginning to end. And the right eye, you can see, has localized hard exudates and extra foveal. And over time, these exudates went down, reduced. They did not threaten the fovea, and his overall retinopathy improved. And this was the right eye. Left eye, he had more significant hard exudates, and they were approaching the fovea. The macular edema was closer to the center of the fovea, and he had worse edema. So the question would be, which eye, how did I treat this patient? Did I treat them both the same, or did I treat them differently? Here are the scans. Here's the scans in the left eye to show you the more the hard exudates and the edema threatening the fovea a little bit more closely. And this, the top slide is from yesterday, and the bottom slide is from 2 years ago, showing dramatic improvement. And the exudates never approached or threatened the fovea, and his vision remained 20/20 throughout. And here's the right eye. The right eye has a little bit more, and this is waxed and waned a little bit, the temporal extrafoveal hard exudates and intraretinal fluid. He never developed subretinal fluid, and he has been watched. So I don't know if you can guess what I did, but what I did do was I asked him to improve his metabolic control. I met with him 2 more times before treating him, and I only ever treated his left eye. And his right eye, we watched, and overall it's gotten better. And this time is a little bit worse than it has been most of the time. He's never needed treatment in the right eye, but his left eye has dramatically improved, and he has now not had any injections for 9 months. And the next patient I wanted to talk about is this patient who presented, this was in 2017, proliferative diabetic retinopathy in both eyes, vitreous hemorrhage in the left eye. What would we do here at this point? This was his initial OCT on the bottom and his current OCT on the top. And then this is his initial OCT on the bottom here and the current OCT on the top. To shorten or for time purposes, I'm just going to say that the left eye was treated more aggressively in the setting of the vitreous hemorrhage and the thickened macular edema. And this eye is doing very well. And the right eye was treated less aggressively, but it has also gradually improved. Meanwhile, his renal status had deteriorated significantly. When he presented, he had early end-stage renal disease and has been able, through metabolic and weight control, been able to hold off dialysis or renal transplant, and overall has gotten dramatically better. Thank you very much. And I think in these days of the virus of COVID-19, Protocol V has been a comfort to us and to our patients to allow us to tell them that it is safe to wait. It doesn't have to be a visit next month, that we can do pretty well with all the medications, and that we should be able to help all of our patients through this time. Thank you very much.
Thank you so much, Alice. That was great. We're going to go ahead and hold the questions for now. We'll move on to the next talk here in a minute, which will be my talk. So I will be giving the next talk on New Therapies, the Era of Extended Drug Delivery for Macular Diseases. Extended drug delivery for the treatment of macular disease is a reality because of the development of novel therapeutic agents as well as delivery platforms in 2020. Today, I'll discuss both of these avenues. These are my financial disclosures. There is a need for improved efficacy and durability in the treatment of eyes with AMD and DME. For example, phase 3 studies using several anti-VEGF drugs have shown stabilization of vision in over 90% of these eyes, but only improvement in about a third of eyes, achieving 15 or more letters of improvement from baseline. Not all of these eyes achieve a dry retina and therefore may benefit from additional treatment control. In addition, there's a need for improved durability for maintenance of this benefit. Frequent injections are burdensome to both patients as well as caregivers. With the use of Treat and Extend, 6 or 7 visits are still needed in year 1. Similarly, in DME, we see that the visual acuity improvements are limited to 35 to 45% at best in patients at the end of 2 years of treatment. Currently, injectable drugs with increased durability include the anti-VEGF drugs aflibercept and brolucizumab, as well as the sustained-release steroid formulations of dexamethasone and fluocinolone. Novel drugs in development in clinical trials with potentially increased durability include Abicipar, Conbercept, faricimab, and sunitinib. In addition, the novel drug delivery system can potentially deliver ranibizumab at a continuous dose for several months. The newly approved drug brolucizumab addresses the unmet need of durability. Brolucizumab is a single-chain antibody fragment. It is the smallest anti-VEGF molecule that blocks all VEGF-A isoforms. In clinical trials, it has been shown to be non-inferior to aflibercept. In the phase 3 Hawk and Harrier studies, brolucizumab was compared to aflibercept in a non-inferiority study. Following 3 loading doses of brolucizumab, dosing was performed Q12 or Q8 weeks, and this was compared to aflibercept dose Q8 weeks. The primary outcome was the mean change in visual acuity. As seen on this table, the mean visual acuity change was similar between brolucizumab and aflibercept, despite the increased dosing interval used for brolucizumab. Furthermore, more than 50% of patients were able to maintain Q12-week dosing after initial loading with brolucizumab. Of these, 82% in the Hawk study and 75% in the Harrier study at week 96 maintained Q12-week dosing. Moreover, the OCT showed better resorption of intraretinal, subretinal, and sub-RPE fluid when treated with brolucizumab compared to aflibercept. Based on these results, brolucizumab was approved by the FDA in October of 2019. However, following its approval, there were reports of inflammation noted. There have been 26 eyes with reports of retinal vasculitis through April 1st of this year. Of these, 22 show occlusive retinal vasculitis, as shown on these photographs and fluorescein angiograms. Of the 26 eyes that had retinal vasculitis, all had prior anti-VEGF treatments with a mean number of 39 treatments. The vasculitis onset was early. 88% occurred after 1 or 2 injections, with a mean time to presentation of 46 days after the first Brolucizumab injection. The package insert does state that there is a rate of 4% of uveitis. It is recommended not to use Brolucizumab if there is any inflammation present in an eye. Let's turn now to Abicipar pegol. Abicipar pegol is a DARPin. DARPins are molecules that are based on anchor and repeat proteins with high specificity and affinity for a target, in this case, VEGF. The molecule is small, 34 kilodaltons in size. It is more stable than an antibody, and it has a longer half-life than the typical anti-VEGF agents. Abicapar's half-life when injected into rabbit eyes is 6 days compared to 3.6 days for aflibercept and 2.5 days for ranibizumab. Its size, affinity, and longer half-life allows it to have a potential dosing interval of 12 weeks. In the Phase 3 Cedar and Sequoia studies, Abicipar dosed Q8 weeks or Q12 weeks after loading was compared to ranibizumab dosed Q4 weeks. In this non-inferiority study, the primary outcome was the achievement of stabilization of vision at 1 year. This was defined as a visual acuity loss of less than or equal to 15 letters. The results were similar for Abicipar and ranibizumab, despite the increased dosing interval of Q8 or Q12 of Abicipar compared to ranibizumab Q4. However, in these studies, there were increased rates of intraocular inflammation in the 2 Abicipar arms at approximately 15 to 15.7%, compared to ranibizumab at 0 to 0.6%. This led to a change in the manufacturing process in order to achieve a more purified product. Of concern was the rate of retinal vasculitis, which was 1.9% for Abicipar Q8 and 1.6% for Abicipar Q12, as compared to 0% for the ranibizumab-treated eyes. This led to a change in the manufacturing process in order to achieve a more purified product. This modified formulation of Abicipar was tested in the open-label MAPLE study. In MAPLE, 123 eyes were treated with Abicipar. The rates of intraocular inflammation were 8.9%. Importantly, no cases of retinal vasculitis were seen. FDA approval is currently sought for Abicipar. Let's turn now to Conbricept. Conbricept is a fusion protein containing the extracellular domains of VEGF receptor 1 and 2, and it blocks VEGF's A, B, C, and placental growth factor. It has a stronger binding affinity to VEGF than aflibercept, and because of this, it has the potential to be dosed at Q3 month intervals following loading. In the Phoenix study, immediate Conbricept was compared to delayed Conbricept. That is, monthly Conbricept times 3 followed by Q3 month dosing was compared to sham treatment initially for 3 months and then the similar dosing. We see here on the graph that Conbricept-treated eyes achieved marked improvements in mean change in visual acuity compared to the sham-treated eyes. And this improvement was maintained despite the quarterly dosing interval implemented after the 3 loading doses. Because of these improvements, both in visual acuity and OCT, Conbricept was approved for use in China in 2013. In the United States and elsewhere, the PANDA study is being conducted. In PANDA, Conbricept 0.5 milligrams dosed Q8 weeks is compared to Conbricept 1 milligram dosed Q12 weeks after loading, and these are both compared to aflibercept dosed Q8 weeks after loading. This study is fully enrolled. Let's turn now to combination therapies, specifically that of an anti-VEGF and an anti-Ang2 molecule. Combining drugs with different sites of action or different mechanisms of action potentially can achieve synergy, resulting in increased visual acuity outcomes and reduced treatment burdens. This molecule, faricimab, is a bispecific antibody with one arm binding VEGF and the other binding Ang2. The rationale to bind VEGF and Ang2 is that both are co-regulated in the neovascular AMD and ischemic disease states. Both act together to promote neovascularization and vascular permeability. In addition, retinal inflammation is involved in the pathogenesis of neovascular AMD and DME, and Ang2 can signal through the integrin pathway and lead to promotion of inflammation and angiogenesis. In addition, Ang2 is involved in the inflammatory event involved in endothelial cell permeability and blood-retinal barrier alterations. Specifically, an Ang2 blocker can block the infiltration of leukocytes into the retina, which occurs in disease processes. In the phase 2 AMD stairway trial, faricimab dose Q16 weeks or Q12 weeks after loading achieved visual acuity benefits similar to that of Q4-week ranibizumab, as shown on this slide. In addition, faricimab, despite the longer dosing interval, still achieved significant gains of 15 or more letters from baseline, similar to that of ranibizumab. The OCT improvements were also similar. In the phase 2 DME Boulevard study, faricimab dose monthly was compared to ranibizumab dose monthly. At the primary endpoint of month 6, the mean change in visual acuity for the higher dose of faricimab was 13.9 compared to 10.3 for ranibizumab. And you can see that the slope of the curve for faricimab is still increasing at the end of 6 months, suggesting that further treatment can result in further improvements in visual acuity. And this is in contrast to the slope of ranibizumab, which flattens out towards the end of the treatment. The phase 3 AMD, Tenai, and Lucerne studies are fully enrolled. In these studies, patients with neovascular AMD have been randomized to receive the aflibercept Q8 weeks or faricimab Q8 to Q16 weeks based on a personalized treatment interval. The phase 3 DME Yosemite and Rhine studies are also similarly fully enrolled. In these studies, patients were randomized to receive faricimab Q8 weeks or faricimab at a personalized treatment interval or aflibercept dosed Q8 weeks after loading. Let's turn now to sunitinib. Sunitinib is a tyrosine kinase inhibitor that selectively blocks receptors involved in angiogenesis, specifically VEGF, PDGF, as well as other cytokines. Microparticles containing sunitinib are the formulation used in GB102. These microparticles, when injected intravitreally, result in the formation of a depot of sunitinib. A 50 microliter injection can result in a depot that lasts up to 6 months. Eventually, the depot degrades into lactic acid, glycolic acid, and the MPEG following release of sunitinib. The phase 2 AMD Altissimo study is fully enrolled, and the phase 2 DME RVO study is currently ongoing. Let's look now at other extended drug delivery systems, such as the sustained release steroid implants and the port delivery system. Let's turn now to the dexamethasone implant. This implant is injectable in the clinic and slowly dissolves over 90 days with release of dexamethasone. The implant itself degrades into lactic acid and glycolic acid, which eventually becomes CO2 and water. This implant is effective in vitrectomized eyes and has been approved for use for DME and RVO macular edema. In the phase 3 DME MEAD study, more eyes treated with dexamethasone than sham achieved a 15 or more letter improvement in vision and a significant reduction in the central retinal thickness on OCT. Approximately 2/3 of dexamethasone-treated eyes developed a cataract compared to 20% of sham eyes. IOP elevation was seen in 30% of the dexamethasone eyes compared to sham eyes. Based on these results, the dexamethasone implant was approved for use for DME in September of 2010. In the phase 3 FARVO Geneva study, eyes with macular edema from branch or central retinal vein occlusion were randomized to receive either dexamethasone or sham. The time to achieve a 15 or more letter improvement was the primary outcome, and this time was shorter for the dexamethasone eyes than for the sham eyes. Based on this, the dexamethasone implant was approved for use in eyes with macular edema from FARVO. Let's turn now to the fluocinolone insert. It is a non-biodegradable polymer tube containing fluocinolone and releases fluocinolone at 2 micrograms per day for up to 36 months. In studies, 75% required only 1 implant for control of DME for 3 years. IOP elevations were seen with the fluocinolone implant, but were less severe than with the dexamethasone implant. The cataract rates, however, are higher for fluocinolone, approximately 80%, as compared to sham. In the phase 3 FAME study, patients treated with the fluocinolone implant did significantly better than control eyes in achieving a 15 or more letter improvement from baseline. Based on this, the fluocinolone implant was approved for eyes with diabetic macular edema. Let's turn now to the port delivery system. This is an investigational drug delivery system which requires surgical implantation but can be refilled in the office. This investigational drug delivery system allows for the continuous delivery of a customized formulation of ranibizumab, and this will maintain a therapeutic concentration in the eye based on passive diffusion from the implant into the vitreous cavity. In the phase 2 LADDER study, patients were randomized to receive intravitreal injections of ranibizumab every 4 weeks or to receive the implant. 3 different concentrations of ranibizumab were used in the implant. At the concentration of 100 milligrams per mil, 80% of patients were able to go 6 or more months prior to requiring a refill for control of their age-related macular degeneration. The use of this refillable implant is being studied in the Archway phase 3 study. Patients with neovascular AMD were randomized to receive the implant containing ranibizumab at a concentration of 100 milligrams per mil or to receiving intravitreal ranibizumab injections monthly. This study is fully enrolled. In conclusion, novel drug mechanisms of action and sustained drug delivery are becoming a reality in 2020. These enable improved visual acuity outcomes and decreased treatment burdens with longer treatment intervals. Thus, the future is bright for our patients with neovascular AMD and with diabetic macular edema. Thank you for your attention. Okay, so I will go ahead and open up the discussion here. Somebody had asked whether inflammation occurs if there's no history of uveitis, and the answer is yes. That has been reported in some of those 26 cases. The recommendation, however, from the company is that if there's any inflammation, since there's a high rate of inflammation that occurs with this drug, do not inject the drug. So let's see, there's another question here. It says, is an improvement of a few letters really significant in the real world? I remember Professor Lawton Smith at BPEI talking about Dr. Killer refractions. Okay, so the question is, how much is really significant? And I would agree, I think if you have 2 to 3 letters of improvement, that's not really significant. And in fact, in CAT, that was used as a rationale for saying that the drugs were non-inferior to one another. However, I think once you start hitting where you're getting at about 4 to 5 letters, that's about a line of vision. So that becomes more clinically relevant. But perhaps more important than that is that when we have longer acting drugs, although they don't hit the efficacy improvement, they hit the durability, and that actually has a big effect on the treatment burden, which I believe is an unmet need. Alice, if you're online there, can you hear me? And please unmute yourself. I have a question for you. There you are. Hey, Alice.
Hi,
Hey, good morning. When you're using these treatments and you see a patient, therefore, who comes in with relatively good vision, on the basis of protocol DRCRV, what do you actually do nowadays? So like, patient comes in, they're 20, 30, you see significant edema, the OCT shows edema. What do you do?
Well, I go through their history and I try and understand what their hurdles are for getting themselves under best control. I try and educate them about A1C and blood pressure and cholesterol, and I show them all the pictures. And I keep the pictures of their eyes up, the OCT and the photograph, so that they know that it's real and they understand, even though their vision's pretty good, they're in trouble. And so depending on who the patient is, if they have significantly impaired vision, then I do go ahead and treat them. And I often actually treat them if I think that it has been going on for long enough that they need to get started. So it's a little bit, how do you say this? I try to treat one eye and not the other and see if they can appreciate the difference and make some improvement by themselves. And that's what I did with the first patient whose eyes I showed at my talk. But then I do not hesitate to treat an eye that has what I think is likely to be significantly vision-threatening macular edema that goes awry. All the patients who are in any of our DRCR studies have reasonable A1Cs, have reasonable blood pressures, are patients who follow up, who come in routinely. So it's about as good as it gets. And in those circumstances, it's safer to watch a little bit with some patients. But in the reality, many of our patients don't fit that bill and are not as well controlled or as on top of what's going on. So I am more likely to treat them. The initial treatments for diabetic macular edema did not include visual acuity. The whole treatment was based on the proximity of the exudates in the fluid to the center of the fovea. And so I know that the modern world, we have to prove vision in most of these studies. So that's forced the visual acuity onto the decision of treating macular edema, which I'm not sure we should really do. Obviously, it gives us more pause to inject an eye that's 20/20 with the risk of potential endophthalmitis. Although it's low, it's real. And I also think that it's important to get them started right away, because sometimes if they don't get started right away, they don't come back, they think it's horrible. They have actually psychologically don't do as well. So it's not uncommon for me to treat them the first day that I see them.
I see. And I'd agree with that. We have a lot of patients in whom, reliability issues are a problem. And there have been published series that come out of Michigan as well as from the Philadelphia area that show us that loss to follow-up, especially in diabetics, can be crucial because they can lose vision. And perhaps it's even more important, when they have PDR and you're treating with anti-VEGFs. I'm curious though, because we have some people who are involved in the ETDRS original studies joining us today. I think there still is a role for laser, in particularly perhaps in some of those patients I described. And I think also in the patients who have non-center involving diabetic macular edema. And I know Dr. Goldberg is here. I know Dr. Jampol, Tim Green, Bill Mieler, you guys were, I believe, involved in the ETDRS. I'd like to get your perspective, if you don't mind. If you can, let's see if we can.
I think there's a role for laser photocoagulation in background diabetic retinopathy, particularly if there is a ring, a well-defined ring or circle or oval of hard exudates adjacent to the center of the macula, particularly when the center of the ring, where there are leaking microaneurysms, is not subfoveolar. In that case, it's a very straightforward and universally successful method to photocoagulate in the center of the ring, sparing the center of the fovea. In that case, within a few weeks, all of the leaking disappears, the hard exudates disappear, and the fovea, the center of the fovea, has never been involved in an edematous or hemorrhagic process. In that situation, I favor photocoagulation almost every time.
And I think most of us agree with you, Dr. Goldberg. And, you know, I would even venture to say, Allison, and, you know, some of your patients that you described that who may not return perhaps, and whom maybe anti-VEGF isn't the best idea, and their vision is good, but they have significant edema, it may not be such a bad idea in some of those patients to try laser as well.
I completely agree.
Jenny, I think one of the issues with photocoagulation in today's world is our residents just don't get exposure.
Right.
I almost feel like I was the last generation to really ever do an MPS laser. And I think that whenever we have an opportunity, I pull a resident in the room and say, you have to see how to do this because you may not see it for the rest of your residency.
Right. I think we're dating ourselves there, but any other comments or questions? No? All right. Wonderful. Thanks so much.
Jay, brief comment.
Yes.
I want to support what Larry Ulanski just said. And that is in reference not to MPS, but in reference to a well-done PRP for diabetic retinopathy.
Absolutely.
The example shown today was perfect. And in particular, the PRP lesions came right down to the arcades. And even more importantly, within half a disc diameter of the nasal border of the optic nerve head. That area around the optic nerve head, particularly nasally, is often not treated in today's so-called complete PRP. You can almost predict that PRP was done by a young person who doesn't want to get too close to the optic nerve head. But the protocol requirements of the original DRS stipulated that the PRP border had to come within 1/2 disc diameter of the nasal border of the optic nerve head.
Absolutely. And I think sometimes our residents who see the PRPs that we recommend are a bit surprised because we do get pretty close to the nerve based on the training that we received from your excellent guidance. So thank you. Any other comments? Okay, so I see Paul Chan's raring to go there. So let's move on here. Our next speaker is Dr. Paul Chan, and he will be speaking on optimizing ROP care. So let me go ahead and share my screen there. 1 second. So Paul, I'm proud to say, is our professor and head at Department of Ophthalmology at UIC. He's doing a great job. He's a director of the Pediatric Retina and ROP Service, as well as the John H. Panton Professor of Ophthalmology.
Good morning. First, I'd like to thank Dr. Lim for organizing this virtual symposium. It's great that we can still do this, even though, of course, we're still sheltering at home and social distancing. And today she asked me to speak about how we treat ROP in 2020 and using laser and anti-VEGF therapy and have that discussion with all of you today. Here are my financial disclosures. I am a consultant for Novartis, and I also am an unpaid scientific advisory board member for Phoenix Technology. I want to acknowledge the number of people that I work with and collaborate with. Very importantly, the team here at UIC who care for the children with ROP, Felix, Chau, Dina Johnson, and of course the IROP group and the GenROP group. So the IROP group, which is led by Michael Chang, Imaging Informatics and ROP, developing artificial intelligence algorithms for ROP, and Pete Campbell, and the rest of the folks at OHSU, and also, of course, Jay Shri Kalpathy Kramer from MGH. Let's start with the case. So this is a good example of a patient who'd had multiple anti-VEGF injections, had Avastin for type 1 ROP. You can see here the birth weight, gestational age, so very young at birth, very light at birth, now presenting to us at 48 weeks gestational age. Here are the images. You can see here the area of NV in the right eye, so you can call that stage 3. Maybe there's some tortuosity. It's hard to say whether this is plus disease or not, but you know, there's tortuosity, dilation, posterior pole. Here's the left eye. It's not as remarkable, but you can see here, even at this late age, the area of avascular retina in the periphery. I like to get fluorescein angiograms. I think it helps quite a bit with the demarcation and understanding exactly where the avascular retina begins And also it highlights the area of neovascularization here, as you can see here in the right eye. Left eye, very clearly you can see the avascular retina here in the periphery. Right, so this is a patient who is treated with anti-VEGF already. What do? And we can do a number of things. We can repeat injection of anti-VEGF, we can laser, we can do combination treatment. Is it reasonable to observe? And we'll have that discussion. When we think about how ROP care has evolved over the years, so back in 1988, so almost 40 years ago, but looking at threshold disease and treating with cryotherapy, and then evolving to using laser treatment, and then of course in 2011 with the BROP trial, and we were treating already with anti-VEGF treatment. But this was really the first prospective study that was published showing the advantage of using anti-VEGF for very, very posterior disease with plus disease. Still, one of the main issues that we face today is that we don't have a lot of consensus on when to use anti-VEGF treatment. We have a lot of good data on when to treat with laser, but not necessarily when to treat with anti-VEGF or even when to use combination treatment. Here's a survey about four years ago by Carl and Baumel, looking at practice patterns, right? So still, many people are using laser, but a number of people have already started using anti-VEGF treatment. So it's out there. Talking about consensus, right? So there's no consensus on the classification of ROP after anti-VEGF. How do we define recurrence? That's not still completely determined. What we're learning over the years is that you can get recurrence later with anti-VEGF treatment. In the BROP study, they found that patients who had aggressive posterior ROP were felt to have a higher risk of recurrence. We also need to follow patients with anti-VEGF very, very closely. So they need weekly exams for a prolonged period of time. And still, there's no consensus on what the ideal follow-up is for these patients. Also, when do you need an examination under anesthesia? When do we perform fluorescein angiograms? This is becoming increasingly important because we are documenting this persistent avascular retina. And of course, when do we do laser to these areas of avascular retina, or when do we do treatment to what we consider as recurrence? Looking at some of the data, this was published about 3 years ago, but it looked at all the literature over that prior to that period of time, trying to make some sense of, okay, well, what's the consensus here? What do we do? So what they found was that there's not a lot of data on safety in terms of long-term data, that anti-VEGF does work. But what they determined was that there's no clear advantage over laser for peripheral zone 2. There's no clear advantage for first-line combination therapy, although a number of reports have come out looking at combination therapy in various protocols. And ROP recurrence is something we really need to consider. Looking at some of the studies and the study results that have been coming out, so the Rainbow study was Lucentis, obviously, so ranibizumab, 0.2, 0.1, and then laser. So looking at those three arms, what they found was overall the unfavorable structural outcome for laser, interestingly, was worse. And there was a statistically significant difference between laser versus 0.2 ranibizumab. Now this is interesting. It raises a lot of questions as well. And I think when you look at the BROP study as well, you look at the laser group versus the anti-VEGF group, and for many of us, who are practicing, our success rate with laser is actually quite good. We're not seeing as much unfavorable structural outcomes. So this also raises the question. And for me, this is something that I'm very passionate about education. How are we training people to do laser? How much variability is there in how people treat with laser? But here, in this study, it does raise the question, why are these patients, why is there such a difference between the ranibizumab 0.2 milligram group and the laser group? When you look at adverse events, really there wasn't a significant difference across the different treatment groups. And looking at the overall study results, you can see here that treatment success rate of 80% was achieved in the 0.2 milligram ranibizumab group versus 66% with laser. Infants treated with ranibizumab 0.2 milligrams are twice as likely to achieve what they define as treatment success versus laser, which was determined to be clinically relevant. The drug was well tolerated. Overall safety profile, at least in the short term, seemed to be good. And then there's a 5-year extension study that's ongoing. There are 2 current ongoing studies, Butterfly and Firefly, that are looking at aflibercept 0.4 milligrams for ROP. Okay, so the Butterfly study just started recruiting these patients, so that'll be interesting to see what the results are for these studies. And when looking at the overall data, so one of the big questions that I think we've been asking for years, similar to AMD, which drug is better? We don't have any definitive data supporting the use of one drug over the other. So there have been reports of bevacizumab. There have been a number of reports of ranibizumab. Actually, Dr. Wei-Chi Wu from Taiwan has published a number of papers and has a significant amount of experience with anti-VEGF treatment. And of course, now Butterfly and Firefly looking at aflibercept. There have also been reports using Macugen and also even Convercept, which is out of China. But again, no clear data supporting the use of one drug over the other. But there are some considerations. Which one lasts longer? What do you actually need to do in terms of the anti-VEGF suppression and so forth? So how do we potentially also improve outcomes? So we talked about drug, we talked about lasers. Laser still is something that we use very frequently, especially for type 1 pre-threshold disease. I don't think that we could have a conversation about anything without talking about artificial intelligence at this point. And the group that I work with, and I'm fortunate to work with Mike Chang and Pete Campbell and those folks, with IROP, we just had our IROP DL get breakthrough status with the FDA. And here are some of the data. What we've shown is that you can monitor disease progression with this system. And obviously this is very important, I think, in the anti-VEGF era in terms of monitoring disease. Can we define recurrence better? Can we define what might need treatment better with some sort of quantitative measure? But we've shown that you can track disease progression and regression with the IROP system. We've talked a lot about a severity score for ROP. How do we use this system? And you can see here on the right that patients who had progression and regression, you can see as they progressed, the score got higher. As they were treated and the disease started to regress, the score got lower. So providing some quantitative means to track disease status, I think, is going to be very important as we go forward, especially as the ROP burden worldwide starts to increase. One thing to keep in mind as well in terms of treatment is that there are cases that we treat outside of type 1 pre-threshold. And we published this paper many years ago, and it still holds. We still talk about these issues of when do you treat outside of the strict rules of type 1, and if you have dragging, if you have vitreous hemorrhage, so forth and so on. Obviously the treatment of choice in terms of laser versus anti-VEGF is a clinical judgment. And of course, we have to think about our patients first, and clinical judgment is paramount. Taking into consideration other things, 2018 were the updated guidelines. So these are just 2 years ago, but it talks about late recurrences and so forth and so on, about these considerations, right? So we have to think about recurrence and what that means, and put that into our algorithm. So in summary, we have two treatments. We have anti-VEGF, we have laser, but still there's not a lot of consensus on when we use anti-VEGF. I think that more and more we're considering this, and we're using this for very aggressive disease, very posterior disease, cases where laser is not optimal, maybe patients who can't tolerate laser or going through that for a prolonged period of time. Anti-VEGF is something to consider, but we have to proceed carefully. OMIC has a number of resources that are very helpful to all of us, consent forms, discussion about safety and efficacy, and what we have to talk to the parents about. But I think patient selection is critical, and of course, patient safety is very important. AI will help us eventually in terms of monitoring disease progression or regression, and I think that very much so would be part of our treatment algorithms and our management. One thing that is new, and we talked about this whole question of what is recurrence and how we define certain things. So now with the anti-VEGF discussion, we're really forced to think about this thoughtfully. And I've been fortunate also to work with the International Pediatric Ophthalmology and Strabismus Council, and I chair a committee that Mike Chang, Graham Quinn, Alistair Fielder chair, which looks at eye crop revisited. We have a great group of people looking at these definitions and these classifications, including Mike Blair, Mike Shapiro, who are also from USC, Cindy Toth, wonderful group, and hopefully we'll have a lot more clarity over this discussion of what recurrence is, and what certain imaging findings are, especially since we have more access to imaging. So the future is bright. I think we have more treatment options for children, and we're using them. I think we just have to use things thoughtfully and cautiously. Thank you very much.
Thank you very much, Paul. We have a bunch of questions. It was a great talk, and we have questions regarding anti-VEGF versus laser in terms of durability and recurrence of the ROP neovascularization. Can you address those issues, please?
Sorry, can you say that again? I'm just, I'm responding to the chat.
Oh,
So
sorry.
I got distracted.
Oh, sure. The question was, using anti-VEGFs, there have been reports of recurrent neovascularization later on, I believe, and somebody's asking, is it more durable, therefore, to use laser versus anti-VEGF, and how do you feel about that?
Yeah, I mean, I think the simple answer is that for the cases that we choose to laser, there is a durability, right? It's almost like when we think of protocol S, right, and diabetes. But here's well, there is a difference. I mean, there's a clear difference to this because ROP is more a developmental issue. But the fact of the matter is, and Dr. Chen asked this question, we don't have clear guidelines around what recurrence is, right? We don't really have. When you look at the literature, people define recurrence in many different ways, and it's very variable among who's publishing the paper, who's writing the manuscript. Mm-hmm. So that's what ICROP is looking at now. So we're trying to define what recurrence is in a more structured way. The durability, I think, is real. Obviously, there's a fail rate. When you look at the ETROP study, the zone 1 and very posterior cases still had a significant fail rate with laser, right? And I think that's why people started to transition to say, well, do we have some other method of dealing with this? And I think the anti-VEGF agents have been very, very good in managing those cases. I mean, in fact, me and Dr. Chau have a case now that we're managing that, we're trying to figure out what the best treatment option is, whether or not to laser or to give injections, especially when there's a lot of tunica and a lot of vasculature in the anterior segment. So durability for laser is good. I think that the issue with anti-VEGF is like I said in the talk, we just have to be cautious about following them very, very closely, and then for a longer period of time, and then also getting our fluoresceins to evaluate the vasculature.
Right. Somebody had asked a question about the serum levels. I know you answered on the chat, but if you could just shortly give an answer so everyone can hear it.
Yeah, it's there, right? I mean, we know this that there's some systemic effect. The papers out of Taiwan, I think, are probably some of the best. in evaluating this. You know, they just have a large number of patients that they've treated with basically all the anti-VEGF agents that we've seen. So I think that the question though at the end of the day though is, does it matter, right? So what is going to happen in the long term for these kids? And you know, I think that with Rainbow, with Butterfly, Firefly, all these studies, we'll have some additional information, but still, we're not going to know for quite some time.
Okay, great. And any comments there, Felix? I know you also take care of ROP.
Yes, there is general concern that anti-VEGF will not provide the long-term stability, and there have been reports of late recurrence, so many do advocate laser after anti-VEGF if there's any concern at all for ROP activity as the anti-VEGF wears off. So laser for more kind of long-term definitive treatment, but even then we have to be careful.
Okay. All right. Thank you. It was a little bit hard to hear you there, Felix. You may want to turn your volume up, but thank you. We'll move on now to Dr. Felix Chau, who will be giving the next talk, and he will be speaking right here on advances in the treatment of retinoblastoma globe-sparing therapy. Felix is an associate professor of ophthalmology and director of the Retinal Bioengineering Laboratory here at University of Illinois. Felix?
It's my pleasure today to speak to you about advances in treatment of retinoblastoma globe-sparing chemotherapy. I have no financial disclosures. In the past, in the pre-chemotherapy era from 1980 to 1994, advanced retinoblastoma eyes were often destined for enucleation even with aggressive treatments, including external beam radiation, plaque radiation, and focal thermotherapy or cryotherapy with comorbid complications. In this typical advanced retinoblastoma case shown here, the eye was eventually enucleated, and from the orbital hypoplasia, you can also tell that external beam radiation was required. Well, the future is now. With advances in chemotherapy delivery, eyes that would have been lost to retinoblastoma from advancing disease, complications, and enucleation are now being spared with chemotherapy. The intravenous systemic chemotherapy, or IVC era, began in 1995 and extends to present. The intra-arterial chemotherapy era began in 2008 and extends to present. And the intravitreal chemotherapy era extends from 2012 to present. And these eras clearly overlap in different ways, and we will explore these going forward. Intravenous chemotherapy usually involves a combination of vincristine, etoposide, and carboplatin given as 6 monthly cycles combined with local consolidation. The drugs vincristine, etoposide, and carboplatin are potent, but do have their potential side effects as listed here. This 1 week old with group C retinoblastoma shown here was successfully treated with 6 rounds of IVC and laser showing type 1 calcified regression. This group D macular tumor was associated with peripheral tumors as well and demonstrated a hyperechoic mass with posterior shadowing from calcium. The tumor also demonstrated seeds distant from the main tumor. This eye was also treated with 6 rounds of IVC and laser with a macular regression of the tumor with calcified components and scarring, peripheral tumor regression with calcium and fibrotic components, and flat scarring elsewhere. Intravenous chemotherapy definitely reduced the need for enucleation and external beam radiation, with an overall salvage rate of about 47% of group D eyes, shown in orange here, and 25% of group E eyes, shown in yellow here, For earlier forms of retinoblastoma, groups A, B, and C, the salvage rates are 90% or better. With the addition of secondary intraarterial therapy to salvage recurrence after intravenous chemotherapy, these salvage rates can increase to 95% of group D eyes and 36% of group E eyes, with possible further improvements by adding intravitreous chemotherapy. In 20-year follow-up of using IVC as primary therapy, the Shields group published their results shown here. And again, for groups A, B, and C, the salvage rates are over 90%. With the addition of secondary plaque or intraarterial treatment after frontline IVC, the salvage rates of group D improved to 71% and group E to 32%, with follow-up up to 20 years. We now enter the intraarterial chemotherapy era from 2008 to present. It took us a while to get here, however. In the 1950s and 60s, Reese and Kiribuchi attempted internal carotid and external carotid access to the ophthalmic artery for treatment, but these techniques were abandoned for toxicity and other reasons. In the 1980s, Kaneko and colleagues in Japan first discovered that melphalan was an effective agent for treating retinoblastoma, and then developed the selective ophthalmic artery infusion technique to use this drug. This slide shows the technique of using an internal catheter within the internal carotid to feed a balloon to occlude the carotid artery beyond the ophthalmic artery. The chemotherapy is then delivered in the carotid artery to supply drug to the ophthalmic artery, and the team acknowledged that some chemotherapy could enter other branches besides the ophthalmic artery using this technique. In 2006, Koban and colleagues developed direct catheterization of the ophthalmic artery using a guide wire and termed this super-selective intra-ophthalmic artery chemotherapy to really isolate the drug to the ophthalmic artery and not other branches. Abramson and colleagues reported initial encouraging results from this study, and IAC soon emerged as one of the first-line management options in retinoblastoma. Shields and other colleagues applied this technique in multiple clinical settings using primary IAC with IAC as first-line management, secondary IAC as secondary treatment after prior failure of other treatments, tandem IAC, giving IAC bilaterally in both eyes simultaneously, and also bridge IAC with starting treatment with IVC, especially in neonates, then followed by IAC. Rescue IAC also refers to the reuse of IAC after recurrent tumor or seeds after previous IAC treatment. This slide shows the microcatheter technique of delivering drug into the ophthalmic artery with pulsed delivery. The drugs typically used for intra-arterial chemotherapy include melphalan, topotecan, and carboplatin at the doses listed here. Treatment protocols worldwide, however, are highly variable based on age, severity, and extent of disease, and treatment center experience. Suzuki in Japan uses melphalan as a single agent, while Abramson in New York uses a combination of melphalan, topotecan, and carboplatin. The Shields group in Philadelphia uses melphalan as a single agent with the addition of topotecan for cases of extensive seeding. IAC is usually given every 4 weeks for 3 sessions as the most common regimen, where more or fewer sessions can be given as needed. Groups B and C eyes indeed may respond with just 1 or 2 treatments, and focal treatments can also be used after IAC for local tumor control. Repeat IAC after prior IAC recurrence often requires 3 or more sessions, and usually with higher doses of melphalan and topotecan. IAC is typically avoided in those less than 6 months old in most centers because of the small anatomy and the difficulty of cannulating the ophthalmic artery. The indications for IAC include primary first-line treatment in unilateral retinoblastoma groups B, C, and D, and bilateral retinoblastoma in groups D and E. IAC can also be used as second line or secondary therapy after prior treatment failure for recurrent or persistent tumors with seeds. Contraindications include eyes with neovascular glaucoma, hyphema, vitreous hemorrhage, aseptic preseptal or orbital cellulitis, and pretisical eyes. If there is radiologic evidence of optic nerve extension or scleral extension, extraocular or orbital extension of disease, or trilateral retinoblastoma, or patients with known systemic metastasis, well, in these cases, because of the advanced nature of the disease and the risk of systemic problems, systemic therapy is probably a better option. On the flip side, tumors that are smaller or amenable to focal treatments or even intravitreal treatments can be employed. The concern is that IAC, of course, does not have systemic chemoprotective effect, and therefore systemic micrometastasis is a risk in advanced intraocular and extraocular disease, and metastasis can go clinically undetected in these advanced cases and lead to death. Yosef, in their systematic review, reported a 2.1% of metastasis following IAC. This slide summarizes the experience of the Shields group in their first group of IAC cases with primary treatment with IAC. They had a salvage rate of 94% of group D eyes and 36% of group E eyes. This slide shows a group C eye that was successfully treated with 2 sessions of IAC. This slide shows a group D retinoblastoma that was successfully treated with 3 sessions of IAC. And here's another group D eye that was successfully treated with 2 sessions of IAC. As secondary treatment, IAC achieved a globe salvage rate of about 62% after failure of other techniques, including prior IAC. This slide shows recurrence of retinoblastoma after systemic IVC, where IAC provided proper tumor control. This slide shows the fellow eye of the same patient where tumor recurrence was found after IVC, and again, intraarterial chemotherapy provided better control of this tumor. In this case of sporadic unilateral retinoblastoma, there was recurrence of tumor after intravenous chemotherapy, and again, intraarterial chemotherapy provided adequate control of this recurrence. This slide summarizes the world experience at multiple centers in trying to use intraarterial chemotherapy to salvage eyes according to International Classification of Retinoblastoma. The results are highly variable. In Group D, the salvage rates range from 30% to 100%, and in Group E, the rates range from 9% to 90%. Intraarterial chemotherapy can be used with or without intravitreal chemotherapy. The Shields group reported here an overall globe salvage rate of 88% using IAC alone for Group D in orange, and 58% using IAC alone for Group E in yellow. These rates were pretty high compared to previous studies. The addition of intravitreal chemotherapy for more advanced eyes with vitreous seeding also had relatively high salvage rates with 69% of Group D and 57% of Group E eyes. Complications such as vascular events are known to occur. This slide shows some of the complications, including choroidal atrophy, optic neuropathy, and vascular events in the retinal circulation. Slide shows worldwide outcomes and complications. I refer you to the reference below where this table comes from. It shows how different centers around the world have fared in terms of globe salvage, as well as the rates of different complications. We now enter the intravitreal chemotherapy era from 2012 to present. This treatment is for active retinoblastoma vitreous seeds, which can definitely threaten globe salvage. Shields, in their review of 40 consecutive cases, achieved complete seed resolution in 100% of eyes and globe salvage in 88% of eyes. They discovered that in the era of IAC alone versus the era of IAC plus intravitreal chemotherapy, their overall enucleation rates have declined, and especially their rates of group E enucleation have declined using the combination of IAC and intravitreal chemotherapy. Treatment is commonly with intravitreal melphalan at a dose of 20 to 30 micrograms given through the pars plana with cryotherapy at the injection site to prevent seeding. Treatment is again for refractory vitreous seeds, and it's important not to overdose as this can lead to ptysis. This slide shows the technique using a 31 gauge needle through the pars plana with triple freeze thaw applied at the needle site to prevent tracking of viable retinoblastoma through the needle track. The eye is then manipulated to disperse the drug through the vitreous. The Shields group reported complete control of the vitreous seeds with few complications. The slide shows the clinical improvement in vitreous seeds using this intravitreal chemotherapy technique. Francis and colleagues have published that OAC plus intravitreal chemotherapy provides faster regression than OAC alone, with improvement in disease-free survival with OAC plus intravitreal chemotherapy versus OAC alone, as well as better ocular survival with OAC plus intravitreal chemotherapy versus OAC alone. This slide shows a vitreous cloud and tumor regressing after ophthalmic artery chemotherapy and cryotherapy, but 14 months later there was a recurrence of vitreous seed with a sphere. This slide shows a vitreous cloud and peripheral tumor responding to a combination of ophthalmic artery treatment, intravitreal melphalan, and cryotherapy to achieve complete control. So the future is now. Combinations of intravenous, intraarterial, and intravitreal chemotherapy are salvaging eyes that would have been lost previously. Groups A, B, and C remain high with 90% salvage rates or greater. Group D eyes can be saved from 47% with IVC to over 90% with IAC with or without intravitreal treatment. Group E eyes can be saved about 25% of times with IVC, and this may improve to 36 to 58% with the addition of IAC and intravitreal treatment. It's notable that the salvage rates are highly variable, as listed there with the ranges, and these depend on different treatment centers and protocols that are used. It's important to also remember that enucleation to reduce the risk of metastasis may always remain a life-saving treatment, especially in groups D and E, and that systemic disease needing systemic treatment probably needs intravenous chemotherapy, while focal disease and treatment may benefit most from intraarterial and intravitreal treatment. Thank you.
Great. Thanks so much, Felix. I have a question for you. Is it possible to repeat intra-arterial chemotherapy, or is there a limit to how many times you can catheterize a small vessel in a child?
The usual treatment protocol is 3 times, but it's apparently been reported some going as high as 11 treatments for the really tough refractory cases. So I think the answer is usually 3, and then adding additional experiences as needed. Apparently with one person out there citing up to 11 treatments, it
Wow.
can go more in the future. As the child grows, perhaps the technique becomes easier as the anatomy gets better. But it is true that toxic risks are a concern, and so for that reason, it's a delicate balance to manage the risk of complications versus the potential gain for control of the tumor.
Great. Question, if you saw a child who had vitreous seeding at this point and has retinoblastoma, suspected retinoblastoma, how would you approach that eye? You do the ultrasound, you see the tumor, there's calcification, and there's also vitreous seeding.
Right. At present, I think I would still approach with the intravenous or intraarterial, if available, to control the tumor. And a lot of vitreous seeds can respond even without intravitreal. Only in the refractory case, if the seeds are not regressing properly enough, then I would probably look to intravitreal treatment. Although I think that trend may change going forward. I think some specialists are getting a lot more confident with intravitreal treatment. And so that may become more of a first line along with the other treatments.
Great, thank you. I think it's really exciting. I think you're right. I think the future is now. You know, before, I remember when I first was out, we were enucleating a lot of retinal blastoma eyes, and this was over 20 years ago. And now, you know, we're sparing these eyes, and we're not only doing that, but we're also maintaining their lifespan. So I think it's really amazing the changes that have happened in pediatric retina, you know, in ROP as well as in retinoblastoma. So thank you. So with that, we're going to close this session on pediatric retina, and we are going to go back to medical retina. And we're going to now look at retinal degenerations and look at some cutting edge therapies for those. So our next speaker, I'm going to pull up here 1 second, will be Dr. Robert Hyde. So Rob actually was one of my residents a few years ago, and he's currently a fellow at the University of Michigan, Ann Arbor. And we're fortunate to have Rob come back to join us this summer at University of Illinois, heading up the retinal degenerations section. So Rob will be speaking on retinal degenerations, new insights and treatments for 2020. Rob.
Hi all, my name is Robert Hyde, and I'm currently a vitreoretinal surgery fellow at the University of Michigan Kellogg Eye Center. Many thanks to Dr. Lim for organizing and inviting me to discuss new insights and treatments for 2020 in inherited retinal degenerations. I have no relevant financial disclosures. There's certainly far more to be said on the developments we've seen in the diagnosis and treatment of inherited retinal diseases than can be touched on here, so I hope to provide a bit of an update on a few important topics in the field. When we talk about inherited retinal diseases, we talk about a very diverse and heterogeneous group of retinal disorders, and for most of the previous decades, much of the retina specialist role in caring for these patients was characterizing the phenotypes and counseling patients. However, now in 2020, we're actually at a place where we are treating these patients with gene therapy. It's informative for today to understand a little bit how we got here. In 1990, it was discovered that a mutation in the rhodopsin gene was responsible for a form of retinitis pigmentosa. And since then, we have seen many other mutations, not only for retinitis pigmentosa, but for many inherited retinal diseases in general. By the 2000s, we saw the completion of the Human Genome Project that took over a decade and cost nearly $3 billion. Shortly thereafter, we saw the release of next-generation sequencing instruments, which drastically reduced the cost and efficiency of sequencing a whole genome. By 2017, we saw the first approval for a gene therapy for an inherited retinal disease with Luxturna for a type of Leber congenital amaurosis. And now in 2020, we consider genetic testing and counseling to be standard in the workup for patients with inherited retinal diseases. But there are a lot of genes. Since 1990, the number has grown immensely, and we are now at a point where over 300 genes are believed to be responsible for retinal diseases. That represents more than 1% of all known human protein coding genes. That we have an approved treatment for one form of inherited retinal disease does provide an inspiring proof of concept, but it also sheds light on many challenges ahead as we seek to scale up the breadth of coverage for inherited retinal diseases. So where are we in 2020? I'd like to focus on 3 topics: testing, current treatment challenges, and future directions. We have to be smart about testing, and that means choosing the right test for the patient. The simplest type of genetic test would be to simply test for known familial mutations. That's a very targeted test in which a proband would be tested for the same genetic mutation found in their affected family members. It's relatively inexpensive but highly targeted, and so be prone to missing certainly a large number of genetic mutations. On the other end of the spectrum is a whole genome sequence with vastly more coverage but with added expense and challenges for interpretation. Based on what has been learned from testing at very large retinal dystrophy centers, it has become apparent that a relatively small number of genes are actually responsible for a sizable fraction of all inherited retinal diseases. In 2017, Ed Stone and his colleagues reported their results of genetic testing for 1,000 patients with inherited retinal diseases. They reported that as few as 13 different genes accounted for the genotype in close to half of their cohort. ABCA4 is the most commonly affected gene, accounting for 17.3% of all cases in Iowa, and 20% both in Philadelphia and Toronto centers. This finding, as well as the list of the so-called top 10 genes, have been replicated to varying extent in other clinics as well. Recognizing this highlights the true value of disease-based panel testing over genome sequencing. When routine testing for common genes fails, however, we are out in the open ocean, so to speak. As panel-based testing will miss non-coding variants, very small or very large gene rearrangements, and so on, we have to consider next-generation sequencing of the whole exome or whole genome. However, there is an enormous amount of background genetic variation among individuals, so it is unclear, once we find a mutation, if it may be pathogenic. That makes establishing a diagnosis difficult. So how are we doing? To summarize the performance of several inherited retinal disease centers, when you combine panel-based testing, exome sequencing, and genome sequencing in a given center, we see that on average, a little over half of all patients will receive a genetic diagnosis. That means that the remainder of those patients not only will not receive closure on their genetic risk and so on, but they could be precluded from any future gene-based treatment. How can we increase the diagnostic yield of testing? One strategy is to characterize functionally the mutation of interest. Research out of Dr. Commander's lab at Mass Eye is seeking to develop high-throughput assays to characterize variants that have been found in patients but that are of unknown pathogenicity. This approach has led them to establish a genotype in certain patients. Another strategy is to use a tiered panel-based approach wherein a threshold for rejecting a found mutation is set a priori based on the relative frequency of mutations in the background. This is essentially an implementation of Bayes' theorem and has been used with good success in several centers. In 2020, we are fortunate that accessibility to testing has improved immensely. In short, you can't beat free. The Foundation Fighting Blindness has launched the MyRetina Tracker program, which is a clinical registry run by the Foundation for patients diagnosed with inherited retinal diseases. In partnership with Blueprint Genetics and Informed DNA, the program offers genetic testing and counseling to patients who register and are eligible. To be eligible, patients must reside within the USA and have been diagnosed with an inherited retinal disease for which the program tests. Currently, there are more than 30 inherited retinal disease diagnoses for which they offer testing. Aside from the physician's exam, there is no cost to the patient, and the insurance company is not billed for the testing and counseling, saving the patient, on average, a cost of approximately $2,000 per patient. There are other actors in this field as well. Recently, Spark has partnered with Invitae to offer genetic testing using a 250 gene panel with results within 10 to 21 days, again, at no charge for the patient. Aside from testing, there's a lot that we have learned in the last several years with regard to gene therapy, in particular Luxturna. We use the term gene therapy rather loosely here, and so too does the FDA, as you can see from this rather inclusive definition, but common to all strategies is the transfer of genetic material to treat disease. There are complementary strategies that can be used depending on the type of disease. For example, a disease with a loss of function mutation, as is typical of recessive diseases, is best addressed by a gene supplementation strategy that restores a normal copy of the gene. On the other hand, a disease that leads to a gain of function mutation would not be well treated by supplementation alone, as we would also want to silence or remove the harmful gene from the genome and introduce a normal functional copy. I will confine the discussion to gene supplementation strategies since those are probably the more common. In general, this involved the use of a viral vector to deliver the gene into the subretinal space. Viruses have been or are currently in use in 45 clinical trials for inherited retinal diseases. The print on this list here is too small to read, but as you can see, there are many commercial interests involved, and in many of these diseases, there are more than one clinical trial underway. A viral vector-based approach was taken with the drug Luxturna, which, as I mentioned, was approved in 2017 for the treatment of Leber congenital amaurosis due to the mutation in the gene RPE65. I want to highlight 3 focus areas: safety, durability, and cost effectiveness. With up to 4 years of data and the follow-on study to the original phase 3 trial, there have been a number of adverse events documented. However, with a few exceptions, nearly all of them were ascribed to the treatment with vitrectomy and subretinal injection, including cataract formation and increase in IOP, both about 18%. A very small number of patients experienced retinal tears, ocular discomfort, and so on. Eye inflammation or iritis was present in about 10% of the patients in the study. More seriously, there was one case of elevated IOP leading to subsequent optic atrophy following treatment for endophthalmitis, and one patient who lost vision. Anecdotally, I think that we have seen a similar rate and distribution of adverse effects in our experience at the University of Michigan. What about durability? Remarkably, it appears that patients seem to notice an improvement in their visual function almost uniformly very early after treatment. As you can see in the top graph, patients in the study improved greatly on their multiluminance mobility test very early on and sustained that improvement for up to 4 years. Visual acuity is not a great measure of treatment response in this case, but as is seen in the bottom graph, you can appreciate that on average patients did not suffer worsening visual acuity in the years following treatment. Put another way, patients do not need to be re-injected, which is very important when you consider the cost. Furthermore, one of the concerns investigators had early on with the gene therapy was whether amblyopia or other neurodevelopmental factors may have precluded benefit in treating adult patients with advanced disease. Functional MRI has been very informative in that regard. In 2017, the results of functional MRI testing were reported for 7 of the phase 1 Luxturna patients. As you can see, those patients showed minimal or no visual cortical activation before gene therapy. However, significant increase in cortical activation lasting at least 3 years after gene therapy was observed for all participants. There was also significant associations between cortical activation and clinical measures such as full field light sensitivity threshold, visual field, and so on. Speaking of cost, it's been an understatement to say Luxturna is expensive. Several studies have carefully examined the cost effectiveness of treatment given the hefty price tag. Scott Johnson and colleagues used a health state transition model to calculate the quality adjusted life years for Luxturna treatment and total cost, including direct and indirect medical costs, and found that treatment was favorable with more quality adjusted life years for treated patients. They found that with a lifetime horizon, the total cost of treatment was $2.2 million compared to $2.8 million with standard care. Underlying the assumption here is that indirect costs over the lifetime of the patient, which are substantial, considering that the goal of treatment would be to target individuals at a relatively young age. Finally, they calculated that if the treatment effect diminishes by 50% after 3 years, the total costs are about equal or break even. Similar analyses have been conducted independently and reached similar conclusions. So what should we be looking forward to next as far as treatments on the horizon? I think there are 4 diseases that we can expect will have major developments in the next 1 to 2 years, including Leber congenital amaurosis type 10. It was reported several months ago at Oregon that colleagues for the first time used CRISPR-Cas9 technology to treat an inherited retinal disease. Dr. Stephen Tsang will be speaking to that shortly, so I'll forgo discussion of that for the moment, but instead speak to the 3 other diseases currently in clinical trials, including RPGR for X-linked RP, achromatopsia, and choroideremia. RPGR mutations account for the majority of X-linked RP, which is a particularly severe and common form of retinitis pigmentosa. Just recently published are the results of a phase 1 clinical trial in which 18 patients were treated with subretinal gene supplementation of RPGR using the AAV8 viral vector. While of course safety was the primary outcome, notably these patients showed early improvement of their visual field in a cohort treated with mid doses of the vector, which lasted up to 6 months at the last time point. Interestingly, they also showed that in at least 1 patient there was subretinal inflammation present at 5 weeks after high-dose gene therapy. As you can see here on the top row of the figure on the right, retinal sensitivity by microperimetry was minimal at baseline, increased within a couple weeks following injection, but when subretinal inflammation increased at week 5, there was diminished retinal sensitivity that was transient. At 12 weeks, retinal sensitivity on the microperimetry data returned and the subretinal inflammation subsided. So obviously this early data is enough to make one optimistic about advancing a treatment, but of course there are caveats recognizing the importance of inflammation in this study. Moving on to achromatopsia, also recently published this year were the results of a viral-mediated subretinal gene therapy study. This was, again, a dose escalation study in 9 patients, primarily addressing safety. They observed no serious adverse events. Similar to other studies, however, they did observe some degree of inflammation postoperatively. Notably, they reported that there were improvements actually in visual acuity early in the postoperative period, which lasted at the endpoint of 1 year. The results of the phase 2 trial for subretinal gene therapy for the treatment of choroideremia were reported recently as well. Most of the 6 male patients in this study exhibited advanced choroideremia with reduced visual acuity. As in other studies, they reported that adverse events were largely related to the surgical procedure. The results at 2 years are given on the top in this chart for the treated eye and on the bottom for the untreated eye. As you can see, 1 or 2 individuals treated exhibited durable visual improvement at 2 years, although on average the visual gains were modest compared to the untreated fellow eye. It'd be a little bit premature to conclude too much from this at this point in the study, but it is again certainly encouraging that no significant or unusual adverse events were reported. I would be remiss if I didn't briefly mention that there are many other treatment strategies currently underway using cell-based therapies, optogenetics, and so on, or a combination thereof. Finally, we have to keep in mind that when we consider the best strategies for defining the primary or secondary outcomes, we may need novel functional tests, including microperimetry, mazes, contrast sensitivity measures, and so on. We'll need to develop better tests, more reliable and consistent tests in order to follow these patients following treatment. So with that, I will wrap up. I thank you all for your attention. We'll take any questions you may have.
Thank you so much, Rob. That was great. We're going to hold the questions because our next talk will be by Dr. Stephen Tsang, and it deals also with retinal degeneration. So our next speaker, Dr. Stephen Tsang, is the Laszlo Bito Professor of Ophthalmology, Pathology, and Cell Biology from Columbia University. And we're really excited to have him with us today, virtually, and giving us his talk. It's really a pleasure, Steve, that you can join us. You know, I wish that you could have joined us in person, but nonetheless, this is great to have you here. So I'm pulling up your talk.
Thank the organizers, in particular Dr. Lim and Chen, for the opportunity to share with you some of our ongoing work and how to bring CRISPR to the practice of retina. There's no need for introduction about CRISPR. It's in all over the news media, in Time magazine, in New Yorker. Since I work at the College of Physicians and Surgeons, I'd like to tell you that CRISPR is really a new tool for genome surgery, and I like to distinguish it from the recent FDA approval for using gene as a medicine. Traditionally, physicians, they use drugs, they go to school. It takes the physicians a long time to learn how to look at the color of the urine to make diagnosis. Until the formation of the College of Physicians and Surgeons, surgeons do not go to school, they go to barber shop. And so you can think about the culture of medicine and surgery has been different, and the approaches of using gene as a medicine, as a drug, is different from genome surgery. Using gene as a medicine has a fairly long history, started in the 1990s, and there's a tragic death of a gene therapy patient. Despite that, gene therapy has been approved in December 2017. First in vivo gene therapy approval in US is used in the retina. And I like to contrast how the rapid of both gene medicine and genome surgery in ophthalmology as compared to the rest of medicine. In hematology, sickle cell anemia, mutation was described by Linus Pauling in the 1950s. but all the trials for gene supplementation medicine has failed, and genome surgery has been approved in EMA for sickle cell anemia just a few months ago. In contrast, in ophthalmology, the gene encoding RP65 was isolated in the late 1990s, and gene medicine approval occurred by FDA in December 2017. Genome surgery was first described by the CRISPR form in 2012, and a few months ago, the first patient with CEP290 form of blindness has now been treated in US by genome surgery. The excitement of genome surgery allowed the treatment for both dominant and recessive disorder. I'd like to go over with you recessive disorder, which has been approached by gene therapy. In recessive disorder, you have two defective proteins, one from mom and one from dad. In a healthy person, you get one healthy protein from mom, one healthy protein from dad. In recessive disorder, both proteins are not working. Using gene as a medicine, you can give back a happy protein and the function return back to normal. In a dominant disorder, you have one healthy protein and then one sick protein, typically dominant negative, and the sick protein has destroyed the good protein. If you use gene medicine, it will have the same fate. The transduced gene product will also get destroyed. With genome surgery, you can cut and paste and replace the diseased protein and gene with the healthy one, getting a cure. There are already a few gene medicine trials using gene as a drug, as in choroideremia, an X-linked form of retinitis pigmentosa, and some patients in Chicago receive treatment with gene therapy for rod monochromatism. Now in genome surgery you can is scarred with the CRISPR form 1.0 is scarless genome surgery. You can cut and paste, and no scar is left behind. And a patient in Oregon has been treated by genome surgery already. In this case, the CEP290 gene, there's a intronic splice mutation leading to a truncated protein. The genome surgery can cut out the mutation, leading to a normal protein. We now switch gears to focus on retinitis pigmentosa, the form caused by phosphodiesterase 6, in the reference of taking care of variant of unknown significance. A typical DNA testing result that the patient have 5 different mutations with RP1L1, PROM1, PRPF8, and also NPHP1. And which of this one actually causes the disease presents one of the challenges of precision medicine, known as variant of unknown significance. This is similar in the phosphodiesterase. One of the first patients in my practice, patient came because he got lots of cuts in his legs. The patient with phosphodiesterase have tunnel vision, and extensive salt and pepper retinopathy, as shown in the lower panel compared to a control. And the mice also have lots of salt and pepper retinopathy on the upper panel, and a wild-type mouse, you get very plump vessel and attenuate arterioles in the phosphodiesterase mutant. It's long debated for the last 3 decades. Is it the nonsense mutation in the gene in this phosphodiesterase causing the disease, or this is this XMV retroviral insertion that causes the disease. So our strategy to tell which one is significant is to repair the nonsense mutation. Successful repair with CRISPR of the nonsense mutation, you show the maximal ERG tracing in blue, and the wild type control is in black. The mutant is completely extinguished in the red. And in ocular coherence tomography, you can see that the outer nuclear layer of the treated in blue F1 is comparable to the wild type control. The lower panel F shows that we have left the retroviral insertion intact, XMV28. Both the 5' junction and 3' junction show that it remains intact. But we have fixed the repair the nonsense mutation. Therefore, we have solved this 3 decades long controversy that the nonsense mutation is significant, the retroviral insertion is insignificant. Because the nonsense mutation after CRISPR is sufficient to completely restore the retina back to normal. So showing you one example how to use CRISPR to solve this variant of unknown significance, which is the Achilles heel for precision medicine and next generation sequencing. And in the next few slides, we show you how we can bring it to human trial for dominant disorder. A barrier to bring CRISPR to 1.0 to FDA is there are 150 mutations in the gene encoding rhodopsin, and will be challenging to go to FDA 150 times. The other barrier is that CRISPR repair, homology-directed repair, works better at the G2 phase and S phase of cell cycle, which is challenging to get in the adult photoreceptors. Some of the barriers to FDA trial is this issue of the G2 phase and S phase of the cell cycle. With our CRISPR 2.0 approach, we can overcome all phases of the cell cycle, including G0. The 150 guide RNA for the traditional CRISPR repair 1.0, but we think that 2 guide RNA to 3 guide RNA is sufficient to cover all the 150 rhodopsins. The last part of the challenge is CRISPR is species specific, and we have made a mouse to carry the human rhodopsin C110. Our strategy is ablate and replace due to genome surgery to cut out the bad allele and replace it with a CRISPR-resistant allele. In a recessive disorder, the proteins are either not made or completely non-functional. With external approach, gene medicine give a wild type back, give a normal function. But in our case, we will cut out both the mutant and wild type and replace it with CRISPR-resistant rescues cDNA. The safety is built into the system. There's no cutting of rhodopsin unless there's a rescue cDNA also there. So the guide RNA is put together with the rescue cDNA. If the photoreceptor get a single AAV carrying only the Cas9 CRISPR enzyme, there's no cutting because there's no guide RNA. All the cells that get the guide RNA, they were able to cut only in the presence of the rescue cDNA. We have tried successfully to treat 2 different mutations with the one pair of guide with the treating protein 23 his and also D190N. Just to remind you that we can only transduce in the mice about 1/4 of the retina. In this case, the transduction is marked by the green fluorescent protein. The ERG may not be as robust as we would like to see. In the control, that at this stage we have a row of nuclei, but using just the gene supplementation alone in the middle panel, there's not much difference. With our CRISPR approach, we get morphoreceptor nuclei. Yeah, function is also much better. The red trace is the mutant, the blue trace is the treated, and then the black trace is the positive control. And in the PCR gel, we can show that the expected cut can be recovered from the retina, show that a lower molecular weight product. Now, this is already reported for this protein 23 his and D190N mutation, and we want to now show it work for a third mutation, and this case is C110. This is a child with C110 mutation with autofluorescent ring, and the grandmother, you cannot quite make out the ring. It's quite severely affected. We have done both subretinal injection. In this case, the mice carry the human rhodopsin gene. The red traces represent the mutant. Is diminished compared to the black trace, the wild type control. And in the blue traces are CRISPR-treated eyes. And similar rescue is seen both in the rod-specific responses and the maximal ERG responses. They correlate with the histology. The CRISPR-treated eye has more photoreceptor nuclei, longer outer segment, as seen in the yellow bar, and the untreated one has only 2-3 row nuclei left. In a different C110 humanized mouse, we did intravitreal injection, and in the rod-specific responses, the mutant has in the red trace. The mutant at this stage still have 2-3 row of nuclei, and in the CRISPR-treated one, the blue trace has a better responses, although not as good as the positive control in black. And similar responses are seen that the blue traces show rescue compared to the red trace in the maximal mixed rod and cone responses. So I'm showing to you that CRISPR genome surgery can be used to help to solve the Achilles heel of precision medicine, the variant of unknown significance. And I'll just show you our CRISPR 2.0 strategy allow us to use only 2 RNA to cover all the 150 mutations in rhodopsin to bring it to human trial. For summer reading, I recommend 2 books in CRISPR genome surgery, and also introduces the use of CRISPR in stem cells. There's also a course during FARVO taught by leaders in the field, including Andras Nagy, Chris Saha, Bruce Coughlin, who have all pioneered different CRISPR strategies, and they'll be teaching on May 1st, 2021 in San Francisco. Thank you for your attention, and I'll be delighted to take some questions. These are just fellows and students in the lab that contributed, and mice that volunteered their lives for these studies. Thank you.
That was great. Thank you so much, Stephen. For those of you who don't know, Steve Tsang is one of the world's experts in CRISPR, especially with applications to retinal degenerations in the eye. And so we have Rob Hyde, who's a rising star, and we have Stephen Tsang, the star in this area of treatment. I'd like to open now the platform to questions. Rob, there is a question regarding inflammation. How much inflammation is seen with some of these therapies that you were talking about with inducing, these vectors and different types of treatments?
Yeah, so speaking to the experience that we've had clinically with patients at the University of Michigan, we've seen about, anecdotally, about 20 to 30 patients who have undergone treatment with Luxturna. And we have seen variable post-operative effects afterwards. Inflammation is, in our hands, it does seem to be a little bit higher than what's been reported in the phase 3 studies. However, it does tend to be transient, and interestingly, it has not precluded visual benefit, reported visual benefit in most patients.
And how are you treating the inflammation? Does it require systemic treatment or topical or intraocular?
Yeah, so most of these patients are being preoperatively treated with systemic steroids. And then postoperatively, they are on systemic steroids for a short period of time. We are seeing actually that the inflammation occurs a little bit later. There's a little bit of a delay of about 1 to 2 weeks where we see elevated IOP and inflammation. And both of those are typically managed topically, although in certain cases we have used systemic therapy.
Great, thank you. And Steve, a question for you. I'm wondering, how specific is this CRISPR and what are the possible complications, when we go from the animal model to the eye, like for the PDE that you're getting close to for the humans?
The off-targeting has been an issue. But the National Institute of Standards accept 12% of targeting in vivo. CRISPR being used 2 ways. What I've described to you is in vivo application directly to the retina. CRISPR can also be used to engineer stem cells for transplantation. In those cases, then the many testing strategy that the cells transplanted, you should not have off-targeting. But in vivo application, somehow the National Institute of Standards come up with the 12% to be acceptable. CRISPR is getting more safer and safer every few weeks with a new form of this genetic scissors called Cas9. And different forms are becoming increasing higher specificity, higher on rate, and lower off rate. There's also emerging, just recently published by David Liu from the Broad, to show that base editors seem to work fairly well in the retina. You can think of what I described to you is using a scissors, cut and paste. Some of the newer technology, mostly developed by David Liu, including the base editors. Those are like a pencil and eraser. And maybe even more exciting, that the prime editing that he described can also overcome some of the limitations of the base editors. And those will not cut the DNA and may have a much more safety profile. And this is most fields in medicine move maybe by months or years. The CRISPR field move by weeks.
Amazing. I mean, really, the future is now in retinal degenerations, basically stuff that we dreamed of that we're able to do and cure patients otherwise with incurable disease. There's a question from some of the attendees regarding updates in gene therapy for age-related macular degeneration, geographic atrophy. Either of you comment on that?
So those have not worked yet, but they're different delivery system for the complement and various. You can also gene therapy is really no different from using gene as a drug. So these are also various neurotrophic factors. Those are all in the pipeline. But you can understand from this meeting the outcome measurements for
for dry AMD has been challenging. So most of the field for macular degeneration for gene therapy is try to extend using genes to extend the duration of anti-VEGF, and GA has been challenging because of the outcome measurements.
Thank you. Rob, you were going to comment?
Yeah, I think that it's not a subject I will express to be an expert on, but certainly there's some preliminary data showing that there is some safety with the very early studies that have been done, both in patients with dry AMD and GA, as well as exudative macular degeneration.
And the question also from the audience regarding cone achromatopsia. Any updates on that? What are the latest treatments for that?
So there are a couple of trials, right, for CNG alpha 3 and CNG beta 3 by at least 3 different teams. And I think some of the early results that a lot of these patients are concerned about photophobia. I think it's quite clear that the photophobia goes away, and many of these patients, and I think that will help in terms of patient quality of life. And in terms of the other outcome, there's only some results released from phase 1, 2A data. So and more patients those are all currently being enrolled.
And with these gene therapies, you would think that after a certain time, if a patient gets too old, the therapy may not be effective enough because either the retina is already degenerated, and there's permanent damage done. What's the age cutoff? What would you guys say? Like, whom should we be discussing this with and saying there's hope for you?
I think patients need to have cells. We in the phosphodiesterase model, we show that the rate of decline is the same in a young patient treated or as in the old patient. As long as the patient have cells, there was a concern previously, there may be a point of no return. Mm-hmm. That when a patient is too old, the cell death program is so advanced that it is not stoppable. But we found that if it's a good transduction, good delivery, most of the cells get the gene. As long as you have cells, then we don't see a difference between the rate of decline in old patients versus younger patients.
Thank you. Rob, you were going to comment as well?
Yeah, I think I agree. I think it's also very highly variable depending on the type of disease and the natural history of the disease. I think in a disease like X-linked RP, which is more rapidly progressive than other forms of retinitis pigmentosa, surely thinking about earlier gene therapy would be most beneficial to the patient. A different disease like achromatopsia, for example, which there may be some controversy of whether it is really considered a stationary disease. There may be a longer period of time before we could consider treating a patient and certainly provide better counseling as we see the adverse effects from some of these trials. So I think it's very highly variable, but certainly we want to be able to treat patients when they have a good chance of improvement.
Great, thank you both. I know Dr. Fishman is on the line, as well as Dr. Goldberg, both of whom are experts in hereditary genetic diseases as well as retinal degenerations. Any questions or comments for Rob and Steve?
The only comment I have, Jenny, is that these are really, truly exciting and beautifully delivered presentations. So thanks to both speakers.
Thank you.
Thank you, Dr. Goldberg.
Yes, thanks so much, Steve and Rob. Fantastic. We're going to move on now to a new area known as the microbiome. So this is a little bit unusual, new area of research. And we have one of the world's experts on this that will be discussing this, Dr. Dimitra Skondra. She is an associate professor of ophthalmology at the University of Chicago, and she'll be speaking on the gut microbiome. What is the relationship?
Good morning, my name is Dimitra Skondra. I'm from the University of Chicago, and I'm going to talk to you about the relationship between the gut microbiome and retinal disease. These are my financial disclosures, which are not relevant with this topic of... So first I'm going to talk about the gut microbiome and the gut-retina axis, and then the relation between the gut microbiome and age-related macular degeneration, diabetic retinopathy, and retinopathy of prematurity. So gut microbiome, which is the trillions of microbes that live in our gut, has gained a lot of attention recently, and it seems to have more important roles than initially thought, let's say 10 years ago. Gut microbiome is basically the way the environment and our lifestyle is communicating with our body. It's very sensitive to our dietary input, as well as medications, antibiotics in particular, and the environment that we live in. And these trillions of microbes, they secrete different metabolites that can affect multiple cells, both in the local environment of the GI tract, but also travel throughout the body and reach organs further away and affect our health and different disease status. The interactions between the gut microbiota and the host are very complex, and they are bidirectional relationships. And in order to study such complex systems, specific animal models are very specialized, can be developed, that basically you have different microbiome status that can be either through medications or with transplantations with synthetic or material from other mice, or have the germ-free mice that have no microbiota at all, and then colonize them with specific microbiota strains. The last type of mice, the germ-free mice that I just described, is considered the gold standard, and most of the major discoveries that we have made, and you really to break it down the details of these interactions of microbiome with our body, is using these mice, because you can really isolate the specific mechanisms and do the physiological characterization. These germ-free mice, they require specialized facilities and stuff, and they're very expensive. They're only like less than a handful of facilities around the world. Likely, we have one of the biggest facilities at the University of Chicago. But using the specialized models, despite the practical difficulties, it really allowed us to make some very major discoveries about how the diet affects the microbiome, and also how the host, the metabolites, the genetic background, the diet, and the immune system interact in order to promote specific diseases like inflammatory bowel disease, as you can see here. More and more diseases, even further away from the GI tract, have been shown to be associated: obesity, Alzheimer. It's also a biomarker of aging. Our microbiome changes grow older. And the field of microbiome and eye disease is an emerging field that recently has been discussed more and more. And I was asked to ask a review last year to kind of like show and highlight what are the early findings of these are. We know there is a gut-brain axis, but what about a gut-retina axis? Is it really proven at baseline how the gut directly affects the retina? What are the pathways involved? How these like interactions interplay with specific diseases? The first evidence was about a decade ago that the germ-free mice, which as we discussed is the gold standard, have different retinal lens composition associated with the biomarkers. But the gold standard germ-free studies are really missing. So, and we don't really know what the effect of this status on retinal morphology and retinal stress and inflammation biomarkers. So, in Chicago, we have created the retinal microbiome team to actually try to answer questions. So first of all, we've shown that the germ-free mice have similar retinal morphology histologically with SPF mice, the mice with conventional microbiome, both. And also they seem to have similar retinal stress biomarkers like GFAP and choroid. But we really don't know what are the major pathways involved. And that's why we decided to see the effect of the gut microbiome in the whole retinal transcriptome of the retina. Basically, we analyzed more than 20,000 genes of the retina between germ-free and conventional microbiome. And as you can see here for the volcano plot, there's a very big separation between the mice microbiome and the germ-free, is showing that microbiome really affects multiple pathways in the retina. Regarding out of the 20,000 genes, the top 30 upregulated, downregulated genes, many of these genes are already associated to be known with macular degeneration and other retinal diseases and glaucoma. And regarding the pathways, we have very advanced computational analysis these days. We can actually really look at this very complex data and delineate pathways, and multiple pathways have been downregulated in germ-free mice compared to SPF mice. And many of these pathways are important pathways like the circadian clock, like the longevity pathways, like MP kinase, oxidative stress, mitochondria, obesity, and metabolic syndrome pathways. So the gut retina exists, and we're really just scratching the tip of the iceberg. What about AMD? AMD, we know there's genetic background, inflammation, complement pathway, autophagy, apoptosis, oxidative stress, and then when you advance the neovascular AMD, the VEGF plays a key role. And we know that diet and lifestyle affects the risk for developing AMD. But we're really still missing some of the explanations about how the genetics and inflammation and the diet lifestyle can together. And our team showed for the first time more than a decade ago that actually the diet and the genetic predisposition have a synergistic effect, and they accelerate and exacerbate both wet and dry AMD features in animal models. But really, we didn't really know back then how these two interact. With the new evidence about the gut microbiome and how diet changes the gut microbiome, maybe the gut microbiome will start thinking it can be the missing link. In 2016, the Sapieha group from University of Montreal actually had a very nice study that showed similar findings with our study that, high-fat diet increases the wet AMD features in the wild-type mice. And then when they change the microbiome with antibiotics or with fecal transplantation from other mice that were on normal diet, they seem to suppress the neovascular response in the animal model, and they saw decrease in inflammation biomarkers. And the microbiota that seem to be affected, there seems to be mainly the bacteroides and the firmicutes. Basically, the high-fat diet increase the firmicutes and decrease the bacteroides, and that balance seems to come back when they get antibiotics or they get transplantation with the normal diet. The Taylor group regarding the dry AMD tried the high glucose diet over long term, and they found similar dry AMD features with subretinal and subarachnoid deposits, similar to what we found with the long-term high-fat diet in our mice. And he found that these mice, as they develop these dry AMD features and they've been on these diets for long term, they have a different microbiota composition, again with a particular association, the bacteroides with a more normal phenotype, and the Clostridia, which are part of the Firmicutes family, with dry AMD features. And metabolomics from these mice showed that there's a lot of fatty acids changes in these mice. But they did not really prove that the microbiome is driving. They did not change the microbiome to see the phenotype will change. It was more like an observation, but not causation relationship. The first patient study came out of the University of Bern, Sebastian Wolf's group, and he basically showed that AMD patients have different microbiota composition in the fecal samples, stool samples, compared to 8 mouse controls. It was a small study, about 10 subjects per group, but even with a small study, they started separation, and again, they saw more bacteroides species associated with the controls. And when they look at the specific metabolic pathways in the different microbiota amongst the groups, they found that protein acid, amino acid synthesis, and fatty acid metabolism seems to be the main metabolic pathways differentiating the AMD with the control subjects. Similarly, Phoebe Lin, she had a review about her work in inflammation and microbiome, and mentioned some of her studies on AMD that she's also presented at FARVO. And they look at advanced AMD patients and controls. They also did genetic testing and documented art supplantation, and they saw that there is indeed difference as well in the gut microbiota composition between AMD patients and controls, but they don't seem to be associated, at the most part, with genetic variations on ARIS2 supplementation. And look at metabolic pathways, similarly what the Sebastian Wolf group found. They found the specific metabolic pathways, in particular the fatty acid metabolism, but also the carotenoid synthesis, seems to be differentially expressed in the AMD versus control. We know that AMD, when you dug down about the metabolic pathways, it's really dysregulation of important metabolic pathways in the retina cells and the RP cells that are mainly driven by epikinase and PCG1A, which is a super regulator of energy-based preservation of the cells, and that controls autophagy and oxidative stress and mitochondrial biogenesis. Pathways in the retina. Actually, our group provide the first evidence that in the germ-free mice, these pathways are very majorly affected by different microbiome status, epikinase, mTOR pathway, oxidative stress, autophagy, mitochondrial biogenesis. Multiple genes are highlighted by the blue boxes here seem to be different between the AMD, the germ-free, and the PF mice. Part of the reason that we're still kind of stuck about how to go and really break it down is because we don't have germ-free AMD model models, and laser-reduced is one of the most commonly models that will laser the retinas and develop CNV a week later. But it's a challenge because usually we have to take the mice out, and these mice, the germ-free, which is the gold standard, live in the isolators. But we managed to find a way to laser these mice and reduce CNV and keep the mice sterile, and this has to present in FARVO and should be published soon. And this can be like have many applications to really break down the specific pathways, but also applied in other diseases besides AMD that the laser process is involved. Let's talk about now gut microbiome and diabetic retinopathy. Studies have shown that patients with diabetes have altered gut microbiome composition, and actually they have increased bacteroides and decreased Firmicutes and Clostridial species, kind of like on the flip side I we just described about the studies about the AMD. It seems that the ratio of bacteroides and Firmicutes to correlate with the glucose tolerance and inflammatory response in the gut. There's not much about the gut microbiome and diabetic retinopathy. There's only one very small clinical study that only looked at bacteroid species from a very small number of patients with type 2 diabetes with and without retinopathy and lean subjects. And basically they show that people with diabetes, either they have retinopathy or not, they have more bacteroides than lean subjects, similarly with the diabetes. The best study out there regarding the diabetic retinopathy and gut microbiota is the work by Maria Grant from University of Alabama that basically show that intermittent fasting seems to ameliorate the diabetic retinopathy signs in the retinas. It's hypothesized that intermittent fasting works through regulating the gut microbiota and producing beneficial metabolites that prevent the development DR. And indeed, microbianalysis revealed that intermittent fasting increased Firmicutes and decreased bacteroides and Enterobacteria in the intermittent fasting group. Overall, in this very nice work by Dr. Grant in University of Alabama, she showed that the gut-retina axis seems to be involved in diabetic retinopathy through the bile acid regulation at critical levels that downstream affect the TNF-alpha levels. Let's talk about IROP now. Gut microbiota have been shown to affect several aspects of preterm infant health. In particular, Erica Cloud at the University of Chicago have shown that gut microbiota seem to regulate brain development through the circuitry levels of IGF-1 and neuroinflammation. We hypothesized that gut microbiome may also play a role in ROP. So we decided to put together a team under the guidance of Erica Cloud and determine if there's an association between early microbial composition and ROP development. And in order to do that, we compared the gut microbiome in high-risk preterm infants with type 1 ROP and high-risk preterm neonates without ROP. We found that at 28 weeks, 8 weeks before the ROP development, the babies that develop type 1 ROP have significant enrichment with Enterobacteria in their fecal samples. And several metabolic pathways, especially the ones involved in arginine and other amino acid biosynthesis, were enriched in the babies without any ROP, indicating that they may have this pathway's protective role. The paper has been accepted and should be in press soon. Regarding how this microbiota could affect ROP development, we speculate it's probably through the IGF-1 pathway based on Erica Cloud's work and also our work from RNA sequencing from germ-free retina. So microbiome could be a novel factor of ROP and potentially a target for future intervention in high-risk infants. So I went an overview of the current knowledge between retina disease and gut microbiome. Hopefully in the future we can prevent diseases by modulating the gut microbiota. So stay tuned, it's an exciting field. I would like to thank my funding sources and also my collaborators and the lab members of my team. Thank you for your attention. I'm ready for questions.
That was great. Thanks so much, Dimitra. Question for you. When you get these stool samples from patients, how sensitive is it to their actual current diet? Does it change based on like what they ate, 2 days ago versus today? How do you control for that?
So this is a very controversial topic, but interestingly, our acute change of the diet does not affect the composition of the microbiome. We tell them basically to avoid a big change of their regular diet habits over the few days before we take the sample, but we don't tell them particularly to, do something different. But interestingly, when they look at like daily samples of patients over a course of weeks, it seems to be relatively stable over the course of like days or weeks. So your microbiome on one day should reflect more of your dietary habits over the course of the past few weeks to months, rather than just hit the last day.
I see. I see. And can you comment on why there's that difference with the bacteroides being more elevated in diabetes, but yet in AMD, it's better?
Yeah, I don't have a good explanation, and we don't have a lot of studies. I think it has to do probably with the glucose and how glucose levels affect specific bacteria. But to me, it was to my surprise that is exactly the flip association, that the increased Firmicutes ratio seems to be protective in diabetic retinopathy, but the increased Firmicutes ratio, at least in the animal models, both for dry and wet AMD, and from our studies with diets, seems to be the driving force in the AMD. I don't have a good explanation for that yet.
I see. There's a question here. It says, is there any difference of the microbiome in babies fed with breast milk or industrialized milk?
So nobody has looked at that. Actually, in our study, there was no difference between the number of babies on breast milk versus formula. But the paper just came out that showed that the breast milk is protective, but they don't look at the microbiota. So I think it's possible that can as well contribute.
Great, thank you. Are there any other questions for Dimitra? And this is really wild. We've seen in the ARED study, as well as the work from Joanna Sutton, that certain diets are protective for patients, and that certain people with different diseases, have more propensity, say, for getting complications than others. And perhaps this is one way to kind of tie it together. Do you want to address that?
For me, there's no question that the reason that the diet is associated with risk for AMD is through the gut microbiome. But also, I didn't put this data in this presentation for the interest of time. Diet seems to affect the retina pathways independently of the microbiome as well. So, but it needs to be mostly driven through the microbiome. So I think that the Mediterranean diet being protective, and specific, omega-6 versus omega-3 diets are more like put you to high risk, and the salmon and the nuts be protective. I think that is all tied to promoting a more healthy microbiome.
Great, thank you. So we are, that was wonderful. We are going to go ahead and hear from our sponsors. I'd really like to acknowledge Alcon, Allergan, Regeneron, and Genentech for their support in this meeting. So we're going to hear first from Casey Schmidt here, and then three of our other sponsors. Alcon, I just wanted to let you all know that they are grateful for your support as well, but they are not going to be saying anything. So I'm going to go ahead and turn it over now briefly to Casey Schmidt. After we hear from our sponsors, we'll have a 10-minute break, and then we'll resume again with an exciting program with imaging. So Casey, we'll unmute you here.
Hi, everyone. Yeah, thank you. Welcome, and thank you, Dr. Lim. Guest speakers, UIC faculty, and guests. Under these unprecedented times, I'm so glad we're able to proceed with this program, so thank you, Dr. Lim. I'd like to take a few moments to discuss opportunities and changes here at Allergan. The biggest change is the recent close and acquisition of Allergan from AbbVie, which we are all really super excited about. It's our new global headquarters is now here in North Chicago. So close to home. We're now the 4th largest pharmaceutical company in the world. We will still be called Allergan Retina, an AbbVie company. So super excited. And then as far as opportunities in the future is in research, and with Abicipar for the treatment in neovascular wet AMD, as Dr. Lim outlined in her talk. The FDA has accepted the BLA with the PDUFA date of July 9th, 2020. We're excited and awaiting its approval. If you guys are looking for more information, please let me know, and I can get you in contact with Ivana Rabbani, my medical science liaison. As far as our current drug, Ozurdex, prior to COVID-19, we were growing at a 14% growth rate with double-digit growth year over year over the last 4 years. More and more doctors see the evidence of earlier usage with manageable side effects. So with that said, I just wanted to say thank you again, Dr. Lim, and for putting this together, and everyone stay safe. Thank you.
Great. Thanks so much, Casey. And I think next we're going to hear from Genentech. Let's see who, do we have Mitch de Rosario here?
Yes, I'm here. Thank you.
Hey Mitch, how are you?
Thank you so much for this opportunity. I really appreciate it. I first want to acknowledge the new normal that we're living in. Chicago had the deadliest day about 2 days ago with 4,000 COVID deaths. And I think what I also want to do is express my gratitude toward you because you're at the front line seeing all of these patients.
Thank you.
Can everyone see my screen?
Yes.
All right, perfect. I also want to express my gratitude to you for being in the front lines, to adapting to the new normal, to adapting to the new clinic flows, to the new patient volumes that you're having to deal with. And what I want to do is spend just 5 minutes rather informing and seeking collaboration from you. So Dr. Lim has presented on some of the topics today, but the port delivery system as well as faricimab. So I'm not going to belabor the points. What I do want to talk about is Roche Genentech's commitment to ophthalmology. We're really excited about the science that we're doing. We have about 30 ophthalmologists that are in-house, and they're always seeking collaborations. We're also in the business of product development, but also looking for science beyond product development. And that's something that I want to share with you. I cover about 10 states. I cover from Wisconsin to Louisiana. And if there's one consensus there, is that there's no consistency in treatment paradigm. However, what I always hear universally are 3 things. One is that improving efficacy beyond VEGF, anti-VEGF efficacy. Anti-VEGFs work, but what we're seeing in the real world is different from what we're seeing, what we see in clinical trials. So there's an increased need for extended durability, and then reducing the discrepancy between clinical trials and real world data. So the first product that we have in phase 3 right now is the port delivery system with ranibizumab. It's a surgical implant that can be refilled in the office. Second product that we have in phase 3 trials as well. PDS was for neovascular AMD. Patients have been already enrolled. Faricimab is being investigated for neovascular AMD and DME. Altogether, we have 14 clinical trials that are ongoing at this point, and that includes both phase 3, phase 2, and phase 1 assets. But what I really want to share with you is my excitement about what we're doing beyond drug development. And it is having in-house scientists working on machine learning and computer vision. It's about collaboration with AAO, IRIS, to get real-world data to improve disease understanding. Telemedicine and home-based visual function monitoring is it may be the new normal. So we are adapting to the new technologies that are coming out, as well as something that has been talked about in the morning today, incorporating genomics and biomarkers in our imaging and biomarkers in our drug development pipeline. So with that, I will give the floor back to Dr. Lim.
Thanks so much, Mitch. It's really exciting to see, that Genentech is getting involved in this as well. And for those of us who are interested, I guess we just contact you so we can get involved in some of this.
Yes, please do reach out to me. My email address was on there, but if there's any questions, my name is Mitch de Rosario, and I'm on LinkedIn as well. So please find me.
Great.
Or reach out to your sales rep.
Next, we will hear from Regeneron from Allie Harrison. Allie, are you there?
Yep, can you hear me?
I can.
Okay.
Perfect.
Thank you so much. I want to thank you, Dr. Lim, and then all the executive committee members for giving us some time to present and keeping this meeting going virtually during these challenging times of COVID-19. And I'm really just going to touch on Regeneron as an overview. Obviously, we find ophthalmology and retina is very important, but there's a lot more to Regeneron than just the retina piece. So science and innovation has really been our founding premise and has allowed us to address certain situations like COVID-19 and Ebola very quickly, within weeks actually, in finding antibody cocktails. But we do continue to look at ophthalmology and retina and do research in those areas. We've recently partnered with Alnylam to look at their RNA technologies and how we can partner with them. And we also have the Regeneron Genetics Center, and we have partnered with the UK Biobank, and then also with Geisinger. So we have now sequenced over 1 million patients. So we have the largest genetics center with patient, health records to date in the world. So we're really excited about that. That allows us to really target our medicines very precisely. So we continue to be on the Forbes top 10 list for science, for one of the top innovative companies in the world. So we're excited. But we do have other products. We have Libtayo, which is on our oncology side, Dupixent, which is immunology, and then Praluent, which is our cardiovascular drug. So that's kind of the scope of what we have. But really, we want to thank you all for your continued support on the retina side. We continue to look at opportunities for research within retina. And then really just want to let you all know that during these times, we're here to support you, your patients, your practices in any way that we can. And I'm going to echo what Mitch said, really just feel free to reach out if you all need anything. We are here to support you in any way that we can. And thank you for everything that you're doing right now.
Great. Thank you, Allison. Thank you again to all of our sponsors. It's really wonderful because with their help, we're able to put this on in a virtual mode. So now we're going to take a 10-minute break. I'll have a little slideshow going on here, but go ahead and get your bio break. And thanks again for joining us virtually. If everybody can also look on the chat, we have the information for the CME, how to get CME. Thanks to our sponsors, the CME is without any cost for this meeting. Also, for those interested, this meeting is being recorded by Audio Digest as well, so there will be an enduring form of this. We're also hoping, thanks to the sponsorship, to put out a monograph that describes some of the topics that were mentioned during the symposium. And hopefully we can mail that out to all the retina community. Please let V, my assistant, know if you are having any issues with CME or want to make sure that you're on the mailing list for the monograph. And it's really wonderful to have had you all with us this morning, and we'll be resuming here in a minute. Okay, and it's time. So we will now move on to the imaging section of our symposium. This will be an exciting area. We have some experts in imaging and artificial intelligence who will share with us today their expertise. Let me pull up our first speaker here. It's really my pleasure to introduce my colleague and fellow researcher, Dr. Xincheng Yao. Dr. Yao is the Richard and Lone Hill Professor of Bioengineering and Professor of Ophthalmology at University of Illinois. He is an expert in the areas of retinal imaging and is extremely talented in creating new instrumentations and new ways to image the eye. I've been fortunate to work with him, and together we have an R01 grant. So Dr. Yao will be speaking on inventions and innovations in imaging. Xincheng?
Hello everyone, today I will do a brief introduction for our recent lab work about instrumentation development and retinal image analysis. Retinal imaging is important for eye disease detection and clinical management. The retina in the back of the eye is covered more than half of the eyeball. There are a few technical challenges for current retinal imaging work. The field of view is somewhat limited in traditional funded camera. As we know, a traditional funded camera can cover 30 or 45 degrees. But the retina itself covers more than half of the eyeball. If we consider the angle number from the center of the eye, roughly is covered to 30 or to 40 degrees. The retina itself is transparent for visible light and near infrared light, so the image resolution and contrast can also be limited. The retina is a neural network consisting of multiple cells function together, so the morphological structure and functional information can also be complicated in the retina. In our lab, we're making a few efforts trying to overcome some of the technical limitations. We are working on wide field funded camera development, super resolution image, functional tomography of retinal neurovascular complex, and also quantitative clinical image analysis and eye disease classification. I'll talk about the wide field funded camera project first. Traditional funded camera had a limited field of view. In funded camera, the edge area of the pupil is used for light delivery. The center area of the pupil is for recording light. In other words, the illumination light pathway and emitting light pathway should have no overlap at the pupil. Otherwise, the back reflectance artifact from the surface of the cornea and also from the first surface of the lens can be multiple orders higher than the usable signal from the back of the eye. This is limited field of view in traditional funded camera to 30 or 45 degrees. In order to cover a relatively larger area for retinal examination, we have to shift the field of view to different locations of the retina. This is created complication, and also frequently we need to dilate the pupil. In principle, the illumination light can also be delivered through a region outside of the pupil. Pars plana is a special scleral area. Within that area, the blood vessel and pigmentation level are low. In other words, the transparency of the pars plana is high. That provides a window to deliver the illumination light into the back of the eye. In this way, the available pupil will be freed only for imaging purpose. This will expand the field of view significantly. In principle, the transpars plana illumination will provide the chance to capture the whole retina within a single shot image. This is one demonstration to use transpars plana illumination for ultra-wide field funded image. This is the pediatric funded camera. Clinical RedCam is the popular device for pediatric image. RedCam can provide 130 degrees in a single shot image. In our prototype, using the transpars plana illumination, we demonstrate the possibility to image 200 degrees in a single shot image. As we can see from the picture, we can achieve the far end of the retina. In other words, we can observe the retinal image up to the orocerate. In pediatric funded camera, the imaging probe is the contact mode. However, the contact mode image is not favorable for adult application. For example, for diabetic retinopathy screening, we also need wide field funded camera, but we cannot consider contact mode. Recently, we also demonstrated the feasibility to deliver the transpars plana illumination without contact requirement. This is our benchtop prototype. In this system, we projected one LED pattern to the part planar region without physical contact. In this way, the system will work just like a traditional funded camera for retinal image. This is one example of the picture we captured using the contact-free image mode. For single shot image, it can cover eye angle at 90 or 100 degrees. That's slightly larger than the traditional funded camera. Our next step is to increase the field of view up to 200 degrees or so in single shot image using the contact-free illumination strategy. We are also making some effort to increase the resolution for retinal image. Structured illumination microscopy had been well established for biomedical image, but it's only work for fixed tissue. That means it only can work for cultured cell image or isolated tissue image. The reason is the same need to require multiple sub-image from the same location of the sample. This multiple sub-image is required to reconstruct a super resolution image. This strategy will not be able to work for the retinal image because the eye movement problem. It's difficult to capture the multiple images from the same location exactly over time. Fortunately, the structured illumination can be equivalent to the structured detection. That's the reason why recently, in our lab, we demonstrated the feasibility to use virtually structured detection to enhance the resolution for retinal image. We demonstrated the virtually structured detection first in living animal eye. The virtually structured detection can provide advantage over the traditional thin illumination. This is because if we consider virtually structured detection, we will be able to have a chance to correct the eye movement before we do the super resolution reconstruction. This is a living animal image. We can see the blood flow and a single photoreceptor in the animal eye. Most recently, just a couple months ago, we demonstrated the first in vivo super resolution image of human retina. This is one representing the picture to capture from awake human subject. Each spot that's the single cell choroidal rod of cone photoreceptor. This is the enlarged picture at the bottom right corner. We can see, we can observe the single photoreceptor, or even we can differentiate rod from cone photoreceptor. The quantitative analysis of the photoreceptor can be important for some eye disease detection. Compared to traditional adaptive optic imaging system, our virtually structured detection strategy to increase the resolution for human retinal image can be very simple. This is a proven chance to foster the application of super resolution image in potential clinical application. Our work for function tomograph of retinal neurovascular coupling system is based on animal model. This is one example to show the functional OCT can be used to map the retinal neural response and also vascular response simultaneously. In panel A is the raw B-scan OCT picture. Panel B1 is the OCT undrugged picture to enhance the visibility of retinal blood vessel. Panel A2 is the intrinsic signal. That means stimulus evoked optical response of the retinal neural tissue. Panel B2 shows the stimulus evoked optical chain of the vascular system. So we can see the stimulus evoked photoreceptor response can occur almost immediately after delivery of the stimulation. But if we pay attention to the time course of the vascular chain at the short time delay at the second level. So the functional OCT image of the retinal neural response and vascular chain simultaneously provide the immune platform to study the retinal neurovascular complex mechanism. We are also using animal OCT angiography to study the vascular dysfunction in RD10 mouse model. The RD10 is the rod degeneration mouse model. From this picture we can see, at the beginning, we cannot see difference between wild type and RD10. But in later day, for example at P28, we can observe the decreased vascular structure and density in RD10, particularly the deep layer. Our quantitative OCTA and retinal image analysis work is based on the clinical data in collaboration with eye doctor in our UIC eye hospital. Using digital data processing, we have working on different quantitative features for objective OCTA classification. These features include blood vessel tortuosity, blood vessel caliber, vessel density, perimeter index, or vascular zone area. Recently, we also demonstrated branch point geometry analysis. That's meant to quantify the triangle number at each branch point. Using these quantitative features, we were able to classify diabetic retinopathy and sickle cell retinopathy. This is a joint effort with Dr. Lin and Dr. Chen in ophthalmology. Recently, we have demonstrated feasibility to use OCTA feature to differentiate different eye disease. For example, in this work, we demonstrated the possibility to differentiate sickle cell retinopathy from diabetic retinopathy through machine learning-based classification. We also demonstrated the feasibility to use OCT angiography to predict the treatment outcome for DME. We are also working on differential artery and vein analysis in OCT angiography. As we know, clinical OCT doesn't have the function to provide AV analysis, but artery and vein can be affected in different way by different eye disease. That means differential AV analysis can improve the sensitivity for OCTA detection. In summary, we are working on transplant illumination for wide field fundus camera. We are using virtual destructive detection to enhance resolution for human retinal image. Functional OCT and OCT angiography can be used for the study of neurovascular coupling in the retina. Quantitative image analysis may provide easy classification of eye disease. Thank you for your attention. And also I would like to say thanks to my group member and our collaborator for their valuable contribution to our project.
Great. Thanks so much, Xincheng. That was great. I see that there are a bunch of questions here for you. And so let's see. One of the questions says, how about retinal ganglion cells? Can you in vivo image the retinal ganglion cells like you can for the cones and the rods?
Not really. I mean, the ganglion cell is very transparent. So people, can do ganglion cell, with fluorescent labeling. But without labeling, in vivo image can be very difficult.
I have a question. How feasible is it to use a super resolution imaging of the eye to see these individual rods and cones? Could it be used as a biomarker for looking at response of the retinal tissue to some of these regenerative therapies out there?
What do you mean retinal tissue? This is
the rods and cones. Can you see, is it going to be able to be used clinically soon, or is this mostly experimental, and what's the timeline?
If you're talking about the tissue, it's very easy.
Okay.
The challenge is for in vivo that, like I said, the retina itself is, transparent, and also the aberration of the eye, it's a challenge to the in vivo image of single cell. But if we are talking about the tissue level, it's very easy under microscope.
I see. So we would have to use pathologic samples maybe to study different disease processes at different states, but not able yet for in vivo imaging.
Yeah, exactly. Yeah.
Okay. How about the extra wide angle wide field imaging through the pars plana? That looks rather promising. What are the chances of that clinically to be useful?
For the clinical translation, our challenge is just to work some people, to make a, clinical device and easy to use. You know what I mean? Technically, we have demonstrated the, technical principle, no problem. But, to make a clinical device, it's not can be done, just by a lab team. We are good at the technical demonstration, but we are not, manufacturer, to build a clinical machine.
I see. And one last question with the differential artery and the vein imaging, I'd like to open it up to our attendees to see what their thoughts are on those. We have experts here in retinal vascular diseases ranging from diabetes to vein occlusion to sickle cell. Any of you want to pipe up regarding the differential artery and vein analysis?
We have done, DR and also sickle cell already, right?
Right. So I'm curious about the clinicians. I know, Dr. Goldberg, I'm going to pick on you because I see your picture there. You've done a lot of work in sickle cell, and we see a lot of sickle cell patients in the clinic. We see the tortuosity differences between the veins and the arteries. We see different changes. What are your thoughts on this and where it might lead?
Do you mean the differential analysis?
Yeah, I'm asking Dr. Goldberg, yes, his thoughts on it.
Well, I defer to Dr. Yao. My thoughts are minimal. I think, but I do admire the technology and the innovation. And historically, when I look back upon the value of imaging of the fundus, it's obvious that every time there's been a new technical advance, virtually every time, that's resulted in an avalanche of new clinical and pathogenetic information. So as soon as one can adopt these spectacular, truly spectacular technologies to human disease in vivo, living human eyes, the more exciting the technology will be and the more valuable it will be. And differentiating between arteries and veins will be routine and probably unimportant relative to all the other important contributions that the new technologies will foster and create.
Great. Thank you for your insights.
Thank you.
Okay, wonderful. We'll move on then. And our next speaker will be Dr. Joelle Hallak. Let me get her slides here. All right, so Dr. Hallak is an assistant professor of ophthalmology. She's director of the Ophthalmic Data Science Lab and executive director of the Ophthalmic Clinical Trial and Translational Center. She and I work closely on clinical trials, and it's a pleasure, Joelle, to have you here with us today. Joelle has an interest in AI, and she'll speak on artificial intelligence, imaging, genetic, and demographic factors associated with neovascular AMD. Joelle.
Hello, everyone. First, I would like to thank Dr. Jennifer Lim for organizing this meeting virtually, given the challenges with COVID-19, and for inviting me to be part of it. My lecture today is titled Artificial Intelligence, Imaging, Genetic, and Demographic Factors Associated with Neovascular AMD. I would like to disclose that part of the work presented in this talk is funded by a Bright Focus Foundation grant. This talk will cover 3 topics: a broad overview of multi-view data integration and learning applications for personalized medicine, applications for AMD progression, and future directions with regards to automated systems and AI applications for classification and progression. As you all know, we live in a multifaceted world where data is messy and heterogeneous. Multi-view learning is the branch of machine learning concerned with the analysis of multimodal data. That is, patterns represented by different sets of features extracted from multiple data sources. Data from different sources have different statistical distributions, semantics, and suffer from different levels of imprecisions and uncertainties. It is important to consider these differences for studies involving data integration for personalized medicine applications. This slide presents a taxonomy of integration methodologies classified according to the statistical problem, supervised versus unsupervised learning, the type of analysis to be performed, the type of data, such as similar versus heterogeneous data, to be integrated, and the stage in which integration is accomplished. It is important to consider all these factors when integrating data, as results are affected by the methodological decisions we make earlier on. For example, in AMD studies, we have data stemming from imaging, such as OCT and fundus photos, genetic data, and clinical data, such as visual acuity and type of treatment. For personalized progression studies, we would need to methodologically decide to integrate features from each type of data to develop machine learning or deep learning algorithms. If we were to integrate all the data from imaging, genetic, and clinical for predicting progression, we would need to decide when the integration should happen. There are three different types of integration: early, intermediate, and late. With early integration, we first combine all the views in their raw format in the dataset and then extract features for training an algorithm. With intermediate integration, features are first extracted for each view and then combined to train an algorithm. Whereas with late integration, data are analyzed or trained separately for each view and then final results are combined. There are pros and cons for each integration method, and the decision of which method to follow depends on the data we have and the objective and design of the study. Following data integration, we will be able to perform the various supervised or unsupervised learning algorithms for multi-view data analysis. In this example, biosamples from several experimental techniques, such as genomic, proteomic, and metabolomic data, can be used to identify associations within and between multiple sets of patients and generate integrative models for patient stratification. Following this brief overview, I will discuss applications to AMD progression with an example study that we performed. This slide presents a full AMD risk evaluation pipeline. It was developed by my collaborator, Dr. Luis de Cisternes. The ultimate goal for AMD studies is to include demographic, genetic, clinical, environmental, and imaging data at the outset. The second step includes processing images, and the third step includes feature extraction along with the integration with demographic, genetic, clinical, and environmental data to calculate risk scores for progression in step number 4. Step 5 would then output and classify patients as either low risk for progression or high risk. A pipeline such as this will help with clinical decision-making. Take, for example, a dry AMD patient visiting the clinic. Data uploaded to classify them as low risk or high risk will provide specialists with additional information as to whether they should come earlier than the standard follow-up time point. This is an example study where we integrated imaging, clinical, and demographic data for predicting the progression of neovascular AMD. In this study, we treated each set of features separately to narrow down the most relevant and then integrated the features for final modeling. The main objective was to identify factors associated with conversion to neovascular AMD in patients undergoing treatment for late disease in one eye. The reason being is because the data came from a 24-month phase 3 multi-center double-masked active treatment-controlled trial, which included 686 fellow eyes with non-neovascular AMD at baseline, where their other eye was receiving treatment. As a first step in our pipeline, we used STOCT images to extract features describing the presence, number, extent, density, and relative reflectivity of drusen. Each OCT volume was processed to automatically segment the location of the RPE in the form of a surface and generate a topographic map describing the regions of substantial RPE elevation. The location and extent of individual drusen were also automatically segmented for each OCT volume using a process that takes the segmented location of the RPE layer and an estimation of the inner segment-outer segment junction as inputs to automatically outline drusen within the volume. The results of this processing is a topographic map indicating RPE elevation with respect to a Bruch membrane estimation and the three-dimensional segmentation of drusen locations for each considered OCT volume. The collection of B-scans within the ST-OCT volume and the corresponding three-dimensional segmentation of drusen locations within the volume were processed to generate 15 imaging features. We then ran an automated lasso regression to narrow down and select the imaging features. Drusen area of 3 mm from the fovea and drusen reflectivity were the main features selected. These two features were also significantly associated with conversion to neovascular AMD in our Cox proportion hazards model. We then analyzed the genetic features that are associated with neovascular AMD in a bivariate analysis. Patients in the Harbor study underwent sequencing for 34 hypothesized single nucleotide polymorphisms. 34 loci were identified for more than 12 million variants, including 163,714 directly genotyped, most of which were rare protein-altering variants. After Bonferroni corrections for multiple testing, we found only one SNP to be associated with conversion to neovascular AMD. This SNP is RS6194127 located on the ACAT10 gene. The figure in this slide shows the Kaplan-Meier survivor curves for eyes with conversion to neovascular AMD by this SNP. The log rank test indicates a statistically significant difference between genotypes taking GG as reference, with hazard ratios of 2.31 for AG and 8.54 for AA. However, it is important to note the low distribution of the AA genotype in this patient population. Moving on to the demographic and clinical factors. This table presents the bivariate analysis between these factors and conversion to neovascular AMD. Age, gender, race, smoking status, and median baseline visual acuity were analyzed. We also included the treatment arm that patients were on for the eye that has wet AMD to primarily control for treatment effects. As you can see, there are significant differences with conversion to neovascular AMD between males and females. This figure shows the Kaplan-Meier plot for gender. Log rank test indicates a statistically significant difference between men and women with a hazard ratio of 1.57. This means that women have a 1.57 higher risk of converting to neovascular AMD in the fellow eye when compared to men. After narrowing down the imaging features and analyzing the genetic, demographic, and clinical factors, the features were integrated for final modeling. The table in this slide displays the multivariate associations between variables selected for the final model and conversion to neovascular AMD. Significant associations remained for a drusen area within 3 mm of the fovea and mean drusen reflectivity after controlling for demographic and treatment effects. The hazard ratio for drusen area was 1.45 for every 1 unit increase and 1.36 for every 1 standard deviation increase. That is, for every 1 unit increase in the total en face area of drusen restricted to a 3 mm circle around the fovea, patients had a 1.45 times higher risk of conversion to neovascular AMD. The hazard ratio for mean drusen reflectivity was 3.97 for every 1 unit increase and 1.32 for every 1 standard deviation increase. Similarly, for every 1 unit increase in mean drusen reflectivity, patients had a 3.97 times higher risk of converting to neovascular AMD. To sum up, in this post-hoc secondary analysis of a randomized clinical trial of 686 fellow eyes with non-neovascular AMD, total en face area of drusen restricted to a circular area 3 mm from the fovea, mean drusen reflectivity, and 1 genetic variant were associated with conversion to neovascular AMD after controlling for demographic and treatment effects. As you know, the literature is flowing now with deep learning applications on ophthalmic data. A prime example includes classifying disease from fundus photos and predicting progression. In the previous study that we just described, we used image processing and machine learning techniques on OCT images to identify imaging factors. Deep learning methods such as unit architectures could be another way that can be used for segmenting layers of the B-scan and extracting biomarkers based on en face images. We are currently using similar methods to study progression of AMT and required treatments. This study is another example of using deep learning to predict AMD progression, where Yannek I included genotypes and fundus images to predict an eye as having progressed to late AMD with a modified deep convolutional neural network. In total, they used 31,262 fundus images and 52 AMD-associated genetic variants from subjects in the ARED study. They showed that fundus images coupled with genotypes could predict late AMD progression with an average area under the curve of 0.85. As for future directions, given all the advancements in computation methods, the future will involve developing automated predictions for AMD classification, progression, management, and treatment requirements. It is important to note that the quality of data inputted affects the performance of artificial intelligence algorithms in disease diagnosis, classification, and outcomes probability generation. For generalizability, neural net systems should ideally learn characteristics from populations with varying ethnicities and geographical locations, and adjust to different imaging methodologies used for image production and processing. Lastly, we are not very far from implementing AI-based telemedicine approaches to developing an AI-based cloud computing service for diagnosing AMD and providing medical guidance. Applications such as these will be particularly useful for remote telemedicine applications. I would like to acknowledge and thank all my collaborators and members of my laboratory involved in the work presented here. Thank you again for the opportunity to present at UIC's 13th Annual Retina Symposium. I will be happy to answer any questions you may have.
Great, thanks so much, Joelle. It's really exciting to see that what we found clinically as part of the ARED study and the work by the Bresslers many years ago is now holding true when you put AI analysis into these retinal images for AMD. Basically, the area of drusen, again, the size of drusen, some gender factors, that they're kind of all coming together, and it's supporting that. Knowing that what you feed in to AI algorithms affects the output, just like you said, and you have to worry about, being inclusive. What about the issues of bias, in terms of the data going in? How can we, if you will, overcome that when we're trying to create these programs to analyze, like, say, for AMD?
Yes, absolutely. So the thing about the data is that one big aspect is quality of the data. So with images, it's the image quality taken, it's the, quality and quantity and the quantity of images taken. Now with population characteristics, it's very important because of these data pipelines when you want to develop them, is that you have, and in order to avoid bias, it's difficult to include imaging and clinical and demographic factors from various populations. So including as many as we can, and that's where validation mechanisms and techniques in order to avoid bias, collaborations with other data sharing from other institutions would play a big part. We're hoping that, once these AI systems start to develop more and become more, I would say approaching clinical utility, it's very important for even HIPAA regulations to start thinking about how can we share data amongst each other so that we can validate more, so that to avoid all the bias that may happen, because what happens in laboratories and you move it to the real world is something completely different.
So I'm going to throw another kind of question at you. And this one is something that's coming up, in the publishing. So I'm, part of JAMA Ophthalmology's editorial board, and the issues have been raised about the privacy and security of these retinal images. So technically nowadays, we can use our retina as a biomarker. So It could be like a biometric for entering into, secure areas or for getting, data securely. So people are concerned that when we send these images out, if there's any way they can be traced back, they can later be used for security issues. What do you think about all that? Or is it too much?
No, yeah, I don't know if we've reached that stage yet, but it's true. But there are also methods where they're trying, instead of using images, using the features. So in certain institutions, if you don't want to send the images, maybe we can send you how we developed, the pipeline to extract features and send us the features instead, which are completely kind of, de-identified and they're numeric and all that. Other type of people are using some sort of synthetic data, where they're developing methods to kind of put it in a different way and then send it in actually not to send the actual images for privacy reasons. It's true because people are worried about all these data sharing mechanisms for privacy.
Right. Well, exciting work, and we'll see, where AI takes us. I think it's going to be great for clinical trials to help us set standards and, maybe at some point obviate reading centers and have a more standardized way of looking at all of these. And also, perhaps it may help us detect those patients who are at higher risk, bring those patients in and decrease the screening burden as well.
Yes.
Any comment on that?
Yes. Oh, sorry.
Okay, great. Thank you very much. We will move on now to our next speaker. So our next speaker, it's my pleasure to introduce Dr. Yannek Leiderman, who is my colleague here at the University of Illinois. Yannek is an associate professor of ophthalmology, co-director of the Vitreoretinal Fellowship, and director of the Vitreoretinal Microsurgery Lab. Recently, Yannek has taken a great interest in AI applications towards retinal surgery, for which he has a really strong interest. And this will be an exciting talk on retinal surgery, artificial intelligence applications. Yannek.
Good morning. I'd like to thank my colleague and director of the Retina Service, Dr. Jennifer Lim, for organizing the 2020 Retina Symposium. And Jenny, I'd of course like to thank you for including me this year. I'll be speaking about artificial intelligence applications in vitreoretinal surgery. It may be helpful to start with an overview of artificial intelligence as applied to the field of retina and vitreoretinal surgery. And so let's start with the definition of artificial intelligence. AI is the use of machine-based intelligent agents that mimic cognitive functions that we associate with the human mind, such as learning and problem solving. And one key to keep in mind here is that in contrast to artificial general intelligence, AI really is using computer-based agents that mimic some of the processes that are involved in human thought. One field of AI that is important in image-based disciplines such as ours is computer vision, and that's a field of artificial intelligence that trains computers to interpret and understand the visual world. This is done by processing digital images and deep learning models such that machines can accurately identify and classify objects and then react to what they see. So let's begin with how computer vision works. We can think of it in three basic steps. The first is image acquisition, and that's something that we already do in the operating room and certainly in the clinic. Image processing, in this case using deep learning models that automate a great deal of the image processing, and finally understanding the image. Some of the tools that use computer vision, some of which we're already familiar with, include image segmentation. So this is partitioning an image into multiple regions or pieces that can be examined separately. Object detection, this is the subfield of identifying specific objects within an image. Facial recognition is something that most of us are familiar with, and it's an advanced type of object detection that not only recognizes a human face but can identify a specific individual. Edge detection, that's used to identify the boundaries, the discrete edge of an object or a landscape to better identify what the image is and also where it begins and where another image or object starts. And finally, image classification, grouping similar images and distinguishing them from dissimilar images. So what about computer vision in ophthalmology? Well, all three of these tools, edge detection, segmentation, and key point detection, are already variously applied. Segmentation is something that we probably don't even think of as AI because it's so commonly available in terms of particularly looking at our OCT images using commercial instruments. It's interesting, it's been said that once something effectively becomes common and understood, it's no longer considered AI, but certainly this is an element of computer vision. Edge detection, in this case, you can see we have segmentation and then detection of the margin of the optic nerve head rim as well as the cup. And key point detection is something that we perhaps are a little bit less familiar with, although you can see in this area we've identified the optic nerve head in terms of different segments or slices that are important key points in terms of making a correlation with nerve fiber layer thinning. But this is something that underpins something like facial recognition, whereby points that are ascribed a great deal of importance in their ability to distinguish a face and also one face from another are assigned a priori. So let's switch gears and talk about another element of AI, and that's deep learning. So this is a subset of machine learning in AI that uses networks capable of unsupervised learning from data that is unstructured or labeled. So unsupervised is an important distinction in that in this case, in unsupervised learning, we have to provide a significant data set that's annotated in order for the neural network or agent to learn the parameters that we want it to understand to be able to process information. What are some examples of deep learning in ophthalmology? One with which many people may be familiar was this seminal paper in JAMA by the group at Google that developed and validated deep learning algorithm for the detection of diabetic retinopathy from commercially obtained retinal fundus photographs. So by way of conclusions, using the cutoff that they selected for relatively high sensitivity, the algorithm from two different data sets was able to achieve almost 98% and 96% sensitivity in the two data sets respectively, and also very, very high specificity of 93 and 94% for detecting referable diabetic retinopathy. So this is one example of using deep learning to actually formulate a diagnosis from commercially available fundus imaging instruments and change our management and implement a strategy for telehealth. So let's switch gears now and talk about retinal surgery and some of the constraints in retinal surgery for which AI applications may help us. When we think conceptually about what's happening during vitreoretinal surgery, one constraint is that we're not able to directly visualize the anatomy, as is normally the case on the surface of the body or within a cavity. We're using indirect visualization methods of the anatomy. We have certainly a confined, limited working space, and that's relatively complex. It's spherical, particularly in the setting of vitreoretinal pathologies such as retinal detachment. It's a relatively constrained and complicated three-dimensional surgical space. Our instrument movement is constrained about our surgical ports. So I like to talk to fellows when they're starting out that effectively not only are we trying to build a ship within a bottle, but we're doing so with incredibly delicate tissues. And if there's any damage to those tissues, there can be significant consequences to visual function from this type of tissue damage. So our goal in setting out in this project was to track the position and movement of vitreoretinal surgical instruments in three-dimensional space relative to the position of the retina in order to facilitate real-time intraoperative surgical guidance during pars plana vitrectomy. So here's an example of the types of things that we want to track in order to help provide that guidance. We have a discretely defined surgical instrument. We have a relatively complex surgical anatomy with a tractional retinal detachment here, and some of the landmarks such as the optic nerve head can be obscured. And in this example, we can see that this bent pick in one place is actually making contact with the retina. Obviously that's intentional in this case, but it's the relationship between the instruments and the tissues to which we want to apply AI methodology. So we developed a framework employing both computer vision and deep neural networks to achieve this. One other element of computer vision that's worth discussing is stereo vision. And we use epipolar geometry to reconcile two different images and to derive positions of objects in three-dimensional space. So in many ways, this is what we do with binocular human vision, as well as some of our commercially available stereo cameras in terms of how not only do we achieve stereoscopic viewing, but in this case, derive the position of images from those, that is, derive the position of objects from those two different images. Effectively, the way we do this with computer vision is the generation of disparity maps. And so what our agent is doing is looking in a way pixel by pixel at these images and looking for disparities of pixels in analogous positions in order to derive the depth of where an object is located. So you can see here in this view of an office landscape on the left, the disparity map shows the desk lamp in terms of how it's shaded being relatively closer to the viewer or the camera, whereas the statue is intermediate in space, and you can see the background, the bookcases are relatively distant. Ultimately, that's how disparity map can be interpreted and how it works. The particular network that we're using is a convolutional neural network, or a CNN. First, let's talk a little bit about artificial neural networks in general. So these are a mathematical model that's able to perform tasks without explicit instructions by learning from examples. Training of an artificial neural network is accomplished by providing a large number of relevant samples, in this case images. And these networks are built with layers of artificial neurons, and that's where the term network comes from, which constitute the basic structure of learning in an artificial neural network. Typically, the topology of an ANN includes an input layer with as many neurons as the number of input variables, one or more hidden layers with multiple neurons within the network, and finally an output layer with one or more neurons, depending on the total number of output needed. The way that the layers and neurons are connected is the way that the ANN learns. And one important point here is that the hidden layers, the middle element of the network in this schematic diagram, these are not really clear to us in terms of ultimately the designers or the users, and even at the end of the process, oftentimes we really don't have an understanding of what's going on within the network, just the input and the output. So let's talk a little bit about a particular type of neural network, and that's the convolutional neural network of CNN. So for some classes of data, including images and videos in this case, the particular class of neuron and layer architecture that we use incorporates a convolution. A convolution makes use of a kernel that contains values called weights and shifts throughout the input data. So for images, the convolutional kernel consists of a 2- and 3-dimensional matrix. CNNs are the class of neural networks that use convolution for feature extraction, in this case identifying the location and movement of surgical instruments as well as the intraocular anatomy. And these CNNs are a category of deep neural networks because they generally consist of a large number of these convolutional layers. So how can we apply computer vision and deep learning to intraocular microsurgery? Our implementation in this case is aiding surgical guidance. Let me show you how we do that. We began with stereo videos of vitreoretinal surgery. These were recorded using commercially available technology at 60 frames per second and 2 4K surgical stereo cameras mounted on a surgical microscope. The videos show the retina and surgical instrument being handled by the surgeon, in this case, in this video, removing epiretinal tractional tissue. We had to sample about 11,000 frames in total, and these were manually annotated to be used as a training set for our CNN. And here's an example of the user interface. You can see here the position of the tooltip in contact with the retina, and the circle is just a graphical output display showing where the technology is identifying the tip of the instrument, and each time it comes close to the retina, obviously in this case it's intentional, but to show some of the examples of the guidance that we can achieve, you can have a visual or an auditory proximity warning, an analogy to collision avoidance that is commonly being used in automobiles. But the real power of this technology is in real time being able to recognize and track the position of the instrument together and relative to the position of the retina. In conclusion, we've achieved a proof of concept to show that we can effectively localize the tip of the instrument using CNNs. We can also compute the distance between the instrument and the retina with two-dimensional images. We've achieved this performance in real time, meaning at the tempo at which microsurgery of the eye is performed, and we've implemented a framework for surgical guidance. So in summary, computer vision tools and deep learning have been applied to static retinal imaging, predominantly to aid in clinical image interpretation, but also more recently in clinical decision making. The application of AI in real time to dynamic imaging, such as that used in intraoperative digital surgical visualization, can be used for tool and tissue tracking in surgical guidance. Finally, I'd like to thank some of the people who had a really important hand in doing this work. First and foremost was Mattia De Fata. He's a master's student in our laboratory who did a lot of the heavy lifting in terms of designing and implementing these algorithms. Tanya Bergerwolf, who is now at Ohio State, but ran the comparative population biology laboratory here at UIC and is an expert in computer vision. Christian Luciano, who directs the mixed reality laboratory and is my very close colleague and collaborator, Wei Tang, and in Italy, Marco Santambrogio. Thank you.
Great. Thanks so much, Yannek. It's really exciting to see what is possible out there nowadays. So my question to you is there any role for this for training fellows? Do you think that will help them become better surgeons? And then secondly, is there any role for integrating it with robotics?
Yeah, those are great questions, Jenny, and thank you again, as always, for including me. To the first question in terms of training, I think so. Particularly if we look at other fields, in fact, some of the first AI applications in surgery, and we haven't really had too much of this in ophthalmology, but are using unsupervised learning approaches to discriminate between someone who's an expert surgeon and a trainee surgeon and identify some of those differences. So I think at the same time, surgical guidance in general is probably something that's going to have the greatest utility in teaching or to people who are still along that learning curve in surgery. Although, again, if we look at other fields in medicine or in aviation and other areas, there probably will certainly be applications that can help experienced and even expert surgeons as well. But I think trainees is probably going to be the area that's most approachable.
So is this like a system that you could connect to the microscope so that it would alert you if you're getting too close to the retina? Is that the idea?
Yeah, that's exactly right. So the first iteration, and that's sort of the proof of principle that I've showed you, and we've actually applied this to some other areas and have done even more work in cataract surgery, is really just giving you visual and audible feedback, just as you saw in terms of proximity warnings or overlays with other data to help facilitate the surgery. The next step in that is probably feedback to the instrumentation itself, right? So if you are operating close to mobile retina right now, if you're about to aspirate retina, you have to take your foot off the pedal in the same way we take our foot off the gas in a car. And as you know, in the automotive realm, there's now pre-braking and other technologies that are activated faster than human reaction time. It's not very much of a stretch to imagine that it'll probably be more efficient if an AI algorithm recognizes that you're about to aspirate mobile retina to directly give feedback to the aspiration of the vitrectomy console rather than going through you.
So it's kind of like a step towards having automated surgery in a way, a robot kind of that could help us while we're operating. That's pretty cool.
Yeah, it's a small step, and I think a lot of people get very nervous at the concept of automation of surgery, but less so if we frame it in terms of augmentation and sort of helping us do the things that we're doing anyway.
Yeah, absolutely. Thanks for developing these great new ways to help us become even better surgeons. That was great. All right, so now, thank you so much. It's my pleasure now to introduce my colleague and friend, Dr. Bill Mieler. Last but not least, Bill, we are going to get you on here 1 second. So Dr. Mieler is Professor of Ophthalmology, Director of the Ocular Oncology Service, Co-Director of the Vitreoretinal Fellowship, and the Class Family Professor in Ophthalmology. As you know, Bill is an expert in the areas of tumors and ocular melanoma especially, so he'll be speaking on treatment of ocular melanoma in 2020. Bill?
I wanted to thank Dr. Lim for the opportunity to partake in the UIC Retina Symposium 2020. Obviously, I wish we could all be there in person, yet hopefully this virtual meeting has been beneficial to all participants. So this will be the final talk. I'm going to give an update on uveal melanoma 2020. I have no financial disclosures. Melanomas represent a relatively small, infrequent problem that we see in the clinic, representing 5 or 6 patients per million per year, but does cause concern because of not only concern for visual loss, but in terms of life prognosis as well. Recognize that there are certain clinical features that are of significance: patient age, the size of the tumor, location of the tumor inside the eye, and the anterior border. These are all factors that we look at very critically in terms of determining a clinical prognosis. Histopathologically, of course, when we do obtain tissue, we look for the different patterns. The epithelioid, of course, carries the worsened prognosis for life compared to spindle A and or B, but this is, of course, only in cases that obtain tissue after the fact. Oftentimes, of course, we do get a fine needle aspiration biopsy, which gives us prognostic factor information at the time of treatment as well. We'll talk more about that very shortly. There are a number of things that we look at in terms of so-called tumor activity, a breakthrough Bruch's membrane, as you see on the top image, presence of subretinal fluid on the bottom, sparse drusen, ill-defined orange pigmentation. These are all things that are indicative of tumor activity, yet are not distinctly correlated with prognosis. But we do have a number of features that we look for that do carry prognostic significance. Papers published by the Shields Group, this so-called mnemonic to find a small ocular melanoma. T standing for thickness greater than 2 millimeters, presence of subretinal fluid, visual symptomatology, vision of 20/50 or less, presence of orange pigmentation, echographic evidence of tumor hollowness, and tumors that have a diameter greater than 5 millimeters all are prognostic factors for growth. Transformation from a nevus into a melanoma at 1 year with these various risk factors is roughly 1%, increasing to 14% by 10 years. And the one factor by itself that has the highest hazard ratio is that of a tumor thickness in excess of 2 millimeters, which has a hazard ratio of 7.8. But if you combine all of the risk factors, so 0 risk factors up to a total of 5 risk factors, going from the presence of no risk factors carries only about a 1% risk of growth at 5 years. But if there's 4 or 5 factors, over a 50% chance of growth being detected at the 5-year time frame. So we see patients now with small pigmented lesions, we score them based on the presence of risk factors. The higher the score, the greater the risk that this may go on to evolve into a melanoma. Therefore, of course, this implies most likely we're going to want to treat this patient a bit earlier if they have a number of risk factors. But we have to recognize that treatment itself, of course, carries risks of visual complications. Treatment for the most part is that done with brachytherapy. Here's an example of the plaque, gold shielded, the seeds aligned across the base of the tumor. And this, of course, is the most commonly employed treatment today. Other forms of radiation, charged particle can be done, of course, utilizing proton beam or helium ion. In the best case match series, they seem to have comparably effective tumor containment, although there may be a slightly greater risk of complications from the charged particle treatment since it's delivered in an anterior to posterior fashion, whereas brachytherapy, of course, is delivered from the base of the tumor through the sclera, and the whole eye gets perhaps a bit less radiation. Other treatment options for larger tumors, external beam radiation combined with other treatment options, but for the most part, these are rarely employed. And there's even means of resecting tumors that one's going to utilize even less frequently. Occasionally, as we'll talk about shortly, we'll combine entities such as brachytherapy with bevacizumab, and we'll talk about when that may be employed in terms of lessening the risk of complications. So brachytherapy, once again, is radiation delivered from a point source. Most commonly employed is that of iodine-125. It's a low-energy gamma emitter. Delivers radiation usually over a 4 or 5 day time span, and is effective in controlling tumors roughly 90% of the time for smaller tumors and at least 85% of the time for larger tumors. Advantages are, of course, it does preserve at least some degree of visual function, but as I mentioned earlier, the most commonly encountered complication is that of visual loss from radiation-induced damage to the retina and or macular region. Here's where you want to see tumor on the left pre-treatment, on the right post-treatment, tumor flattening, no significant complications here short of a bit of hemorrhage on the treatment zone. Another example of a tumor, in this case almost 8 millimeters sinking down to 3 millimeters. In this case had no radiation-induced complication whatsoever. Patient did well from a tumor control standpoint as well as a life prognosis. But as I mentioned earlier, though, the complication profile is substantial. Roughly a third to a half of the patients will have some degree of a complication. These here are the less common complications. What we see most commonly is that of radiation-induced retinopathy, optic neuropathy, and or maculopathy. Here's an example of radiation-induced maculopathy. You see the color of the fluorescein angiogram showing some loss of capillary integrity, and the OCT showing cystic thickening. This, of course, relates to radiation delivered at a higher dose. Larger tumors, for example, or those that are close to the macula, give the macular region a higher rate of radiation-induced complications. Can we limit this? Well, if we employ brachytherapy with bevacizumab employed prophylactically, perhaps the answer is yes. Shields published a number of papers in the last 6 to 12 months where they did brachytherapy and started bevacizumab at the time of treatment, gave the medication Q4 months for 2 years. They found that patients had a better preservation of central visual function, but the complications were still not totally eliminated. Younger patients, larger tumors, those that had a more posterior tumor still had a substantial incidence of radiation-induced complications, but perhaps brachytherapy combined with bevacizumab can help a number of patients to minimize the risk of visual loss from radiation-induced maculopathy. There's also a trial forthcoming called the Aura Biosciences or AU011 trial. This was actually started in an earlier phase back in 2017. This involves an injection of a virus-like nanoparticle which binds to the surface of a melanoma via the surface heparin sulfate. Then you treat this with a light-activated treatment, and it helps to destroy the tumor. This was found to be quite effective in the trial that was published in 2019 with a 2-year follow-up. They found that visual preservation was better than brachytherapy roughly 90% of the time, but local tumor control was not quite as good. And the one big problem was ocular inflammation was seen in 85% of eyes, but fortunately quite well treated with anti-inflammatory medication. Now this study is being started again in a little different delivery system. Later this year, the medication will be delivered suprachoroidally, and the hope is that it can deliver the agent to the melanoma. You can treat it with light activation, have a lessened risk of inflammation, and perhaps not only have a good visual outcome, but perhaps even better tumor containment. So our center at UIC is a participating center. This will start recruitment later this year, and will take probably a couple of years to have any appreciable data showing the potential benefit of this AU011 clinical trial. We're looking forward to partaking. Now, what about bigger tumors that are treated with brachytherapy? We look once again for features that try to predict the risk of metastatic disease, tumor cytology, gene expression profiling, molecular targeting, even try to identify circulating tumor cells, although that is certainly a quite limited option at the present time. We know over the years that certain chromosomal abnormalities, whether it's RNA or DNA, can be associated with a higher risk of metastatic disease, in particular that of monosomy 3. Patients with monosomy 3 need to be monitored more closely or perhaps placed in adjuvant therapy, but the problem at the present time is still that the treatments given systemically have had minimal impact on truly effectively treating the metastatic disease or preventing metastatic disease from developing in the first place. But chromosome 3, if you look at the monosomy patients, there's up to a 50% mortality by 5 years, so we need better treatment in patients who are identified as having monosomy 3. We'd love to have a better adjuvant therapy to be given either to prevent metastatic disease or treat it once it develops, but once again, at the present time, this is still significantly lacking. Now, there's a cancer genome atlas developed by the National Eye Institute looking for abnormalities in RNA or DNA findings. This, of course, can be get tissue via finding the aspiration biopsy at the time of brachytherapy treatment. And then these patients are entered into a different classification scheme, groups A, B, C, or D. There's risks known for development of metastatic disease as per the following chart. This data came from the Wills Eye Institute Oncology Service, Jerry Shields, Carol Shields, etc. Group A is diasomy 3 with diasomy 8. Most commonly encountered over half the time, only a 3% at risk of metastatic disease at 4 years. But as you go down into the monosomy 3 groups with the 8q gain, not as common in terms of frequency, but certainly have a much higher risk of metastatic disease, 25% for group C at 4 years, and 40% for group D at 4 years. So once again, monosomy 3 certainly carries a high risk for development of metastatic disease. How do we treat or prevent? Well, once again, a lot of things have been tried. Systemic chemotherapy, immunotherapy, antibodies, MEK inhibitors, checkpoint inhibitors, etc. But the bottom line is that these treatments are really of minimal benefit at the present time. Oftentimes patients become rather ill, and it's a balance between life style versus effective treatment. But at the present time, the prolongation of life is in the range of months at best, but we need better treatments to hopefully extend out and even provide a cure for this problem rather than just a slowing down of the progression of the disease process. If patients have a more isolated form of metastatic disease, for example, a form of hepatic metastases, sometimes you can inject chemotherapy, immunotherapy directly into the liver. Surgically resect, these patients have a better prognosis, but still is somewhat guarded because oftentimes the liver is involved. Sooner or later, other organs become involved. These patients end up having life-threatening processes that develop over time. So to summarize, we look now at small tumors in terms of scoring them for risks for growth. We recognize that if there's only 0 or 1 risk factors present, the risk of developing growth is pretty small. But if they have 4 or 5 risk factors, it's over 50% by a 5-year time span. Brachytherapy can be employed earlier, trying to minimize the risk of growth of these lesions, but brachytherapy carries a number of risks. A study forthcoming by Aura Biosciences, the AU011 trial, once again, an injection into the suprachoroidal space, a targeted therapy, light activation to hopefully kill off the tumor, minimize the amount of inflammation, might prolong these patients' survival and preserve visual function as well. This trial in the suprachoroidal phase will be started later this year. We're partaking in this trial. We hope to see some positive effect of this treatment option as time goes by. Tumors that are larger that receive brachytherapy treatment carries effective treatment roughly 85–90% of the time, yet visual loss is quite common due to radiation-induced complications. Therefore, a number of trials by the Shields and colleagues have shown that brachytherapy combined with anti-VEGF therapy given on a routine basis from time point 0, Q4 months for the first 2 years seems to lessen the risk of radiation-induced complications. But still, if patients are younger, if they have a large tumor or a more posterior located tumor, the risk is still quite substantial, but this does appear to be a beneficial treatment, though this is employed in patients who are at higher risk for developing radiation-induced complications. In terms of metastatic disease, we're lacking effective therapy in terms of prevention and or treatment of metastatic disease. A number of things have been tried. We oftentimes obtain tissue. We try to classify our patients. If they're at higher risk, we certainly try to guide them into a treatment option, but just recognize we need a lot of improvement in our treatment modalities for prevention and or treatment of metastatic disease. This cancer genome atlas has been developed by the NIH back in 2005 and once again classified in terms of A, B, C, and D. Group C and D are monosomy 3 with 8q gain. These are the highest risks in terms of metastatic disease. But still, once again, our treatment options are unfortunately lacking at the present time. But trials are ongoing, which may offer improved survival as more time goes by. So to summarize, the field of uveal melanoma is exciting, challenging. It represents a sight and life-threatening process. We're doing our best to trying to help alleviate fears of our patients and provide effective local tumor control as well as systemic control as well. Once again, I want to thank Dr. Lim for the opportunity to partake in this wonderful virtual UIC Retina Symposium 2020 and be happy to address any questions that may arise. Thank you very much.
That was great. Thanks so much, Bill. Are any questions for Dr. Mieler? Meanwhile, while we're waiting for questions, Bill, I have a question for you. Nowadays, when you say you see a patient, are you going ahead and using an anti-VEGF at the get-go like the Shields recommends when you do your plaques? Or are you basing it based on the size and the higher risk for radiation retinopathy, the more dose that you're giving? Bill, you're muted.
Can you hear me okay?
There you go.
Bottom line is that we are using it more commonly, but not uniformly. The data from the Shields group just came out in the last few months. Prior to that time, the data wasn't quite as strong as what they alluded to in their publications. But if someone has a larger tumor and we're treating within, 3 or 4 millimeters of the macula, we'll tend to treat quite commonly now with supplemental anti-VEGF therapy. I just have a little hard time personally understanding how given every 4 months is often enough. Yet with the data, I think we have to at least give it a try.
And then another question, are you doing genetic testing? And then if you were, like let's say you find somebody's monosomy 3 with a much higher risk versus somebody without, would you then change your surveillance of that patient, or would it not really change it at this point?
Yeah, surveillance certainly will increase to even like every 3 to 6 months rather than on an annual basis. Once again, tissue is, we pose the situation to the patient and we indicate that, yes, we can get a biopsy. If we find certain features, there's a greater chance of metastatic disease. The problem right now still is that there's no real proven efficacy in treatment. A couple of trials are ongoing and there has been prolongation of survival in terms of say 4 to 6 months over no treatment. And it's a decision we try to reach on a case-by-case basis with our patients.
Okay, and there's a question here. It says, have you been using OCTA to guide the risk of radiation maculopathy based on Zographos's data? And do you biopsy, well, I think we addressed it, biopsy and genetically routinely test all your patients?
I didn't hear all that question, Jenny.
Sorry. Have you been using OCTA to guide the risk of radiation maculopathy based on Zographos's data?
Yeah, we're aware of the paper. We even did some of that work ourselves here. Talisa, DiCarlo, myself, and others looked at OCTAs. The answer is not precisely, but we're certainly aware of that and monitoring that as a possible thing to watch for in the future.
And the other question, this is from Dimitra Skondra also, do you biopsy and genetically test routinely all of your tumor patients?
Once again, not all of our patients because that same issue. We don't have highly effective treatment for some of these situations. So we leave it up to the patient if they're interested in obtaining the biopsy. So not routinely every patient now. There were just a couple of papers given at the Retina Festival recently where other centers are biopsying everyone. We haven't quite done it yet.
I see. And, different topic, but if you were looking at a patient with lymphoma, are you doing the IL-6, IL-8s? Are we looking at that? Whatever the levels are.
Those are all routinely done for lymphoma concerns, yes.
I see. Great. Any other questions for Dr. Mieler? If not, that was wonderful. Thanks so much. I am going to go ahead here and just put on a few slides at the end. It's really been a wonderful morning of learning virtually from all of you. I really thank all of you for participating, the faculty for their outstanding presentations, the attendees for participating via chat and also virtually on the computer. I think we've learned a lot about novel therapeutics, imaging, and treatments. We've encompassed artificial intelligence, genetics, and even the gut microbiome. So 2020 really is an exciting time. We're blessed to be ophthalmologists. And I think the era of the future is now. I hope we've convinced you of that. Thank you once again, faculty and attendees. I want to recognize my assistants, V. Stewart, Lori Walker, Anita Horta, and Lauren Kalinowski, who helped put this together. Thanks to Audio Digest. Thanks to our sponsors. I want to hopefully see you all. I mean, it'd be wonderful. We had record attendance today, reaching a peak, I think, of over 135 attendees. So hopefully many of you will venture to Chicago next year, and we can see you at the 14th Annual Retina Symposium, which will be held on March 26, 2021 on campus. So till then, stay well, be safe, and a big virtual hug from me to you. Have a great weekend, and thanks again for attending.